Okay, good afternoon, everyone. Okay. Okay. It's a pleasure to welcome everyone to this the second edition of the virtual Alpha Beta Gamma chapter of Babcock University Nursing Conference. I want to believe that a number of people have joined. Okay, 24 participants already. I think we can start. And then, do I have Mrs. Oyiloye on the call? She's to give the opening prayer.
Yes, please. Let us pray.
Thank you.
Our Father, we thank you this time. We give you glory for granting us the grace to plan this program and to execute it today. Thank you, O Lord, for all our preparation towards the program. And thank you for our keynote speaker. Thank you for all the presenters and for we the listeners. We pray that you be in our midst, that this period will not just be a waste in our life. It will be a time of refreshing that we learn good things from this. And at the end of the program today, have every cause to glorify your name. Thank you because all our gadgets will work together for good and everything will work smoothly to your glory. For in Jesus' matchless name, I have prayed. Amen.
Amen. Thank you, ma'am. Okay, moving.
Amen.
Okay, I will use this time to quickly recognize dignitaries that have been invited to grace this occasion, this conference. I'm trying to, in no particular order, I want to recognize the presence of Professor Mrs. Grace Tayo. I don't know if she's here already. The director for RIC, Babcock University. Are you on the call, ma? Okay. We also have the guest speaker for today, Dr. Ahibe. I think I saw him.
Thank you. Good afternoon, all.
Good afternoon, sir. Thank you for heeding our call. I will also recognize Dr. Oluwabusolami Atekoja, the HOD for the Department of Nursing, Olabisi Onabanjo University. All right. Dr. Sylvia Oge Ofosudu-Amena. She's the Sigma Africa Coalition Coordinator. Is she here? Okay. Professor Florence O. Adeyemo, the Dean School of Nursing Science, Ladoke Akintola University of Technology. Mrs. Dorcas Shonibare, Director, Nursing Services, Ministry of Health, Lagos State. And Mr. Ademola Shafiu from the Crescent University, Abeokuta. Am I audible? I think I'm seeing a message.
Yes, please,
We can
yes.
hear you clearly.
Okay, thank you. So as our dignitaries come in, I will try to flash back to recognize them. So as we speak, we have the presence of Dr. Anyebe only as one of our dignitaries. So we'll move to the next program. So I'll invite Mrs. Adito Wadewoye to introduce us to the conference. Thank you.
Thank you so much. Good morning, good afternoon, good evening, all our colleagues in the field of nursing research all over the world. And welcome to the opening of conference on sharing insight, advancing care, and disseminating nursing research for the future. Today, we can see that we gather and share our latest findings and advancement in the field of advanced nursing care. This conference will serve as a platform to disseminate our research and engage in meaningful discussion that will push the boundaries of our knowledge and understanding. So let us make the most of this day to foster collaboration and innovation in improving our practice and ultimately the quality of care for our patients. So throughout the day, we have presentations, we have poster displays and discussion that will be led by our experts in the field of nursing, all aimed at expanding our knowledge and improving our practices. I am excited to see the valuable insight and ideas that will be shared and discussed here. And I hope that we will all leave this conference with new perspectives and strategies for advancing care and disseminating nursing research. So let us begin. Relax on your seat and listen. Thank you all. You are all welcome once again.
Thank you, Ma, for that brief introduction. We look forward to enjoying the program. God bless you, ma'am. Okay, the welcome address or the declaration of the conference open by the President, Alpha Beta Gamma Chapter of Sigma, Dr. Clara Lawal. Please come up stage, ma'am.
Good day to everyone. Am I audible?
Yes,
We can hear
yes,
you.
ma'am. Yes, ma'am.
Thank you very much. I'm glad to welcome all of you to this virtual conference this day. I am very, very happy, as it's one of the events that we are supposed to do, and thank God that it is coming up. Alpha Beta Gamma is a chapter of Sigma International Honor Society that is situated in Indianapolis in the USA. All our members are ex-heads. Specifically, all nurse leaders have master's or a PhD degree, while student members must be in the 4th or 5th year of study in the university, and they must have a CGPA of not less than 3.5 in a 4-point scale. And I'm sorry, you are moving too fast for me. I can't follow you. So we hope that, I'm sorry, that everyone that is here will be able to be with us as we continue with this program. I'm sorry, this. All members are expected to lead the research and to mentor others. And this conference is aimed at showcasing research conducted by nurses in this global world of technology. The theme of the conference is very apt, and we promise that we'll continue to have annual conferences to accomplish this goal of presenting nursing research to our colleagues. We are keen to welcome new members from interested nurse leaders present at this conference. At the end of the conference, we shall send letters of invitation to interested individuals present who will want to publish their research. If they are interested individuals, please kindly contact Professor Adeyemo for the necessary assistance. I wish to specially thank the committee members that worked tirelessly for months to put this virtual conference together. It was not an easy task, I know, and I say God bless you all. The Lord that knows how to reward shall reward you all. I thank you very much. I hereby declare this conference open in the name of the Lord. I wish you all good deliberation as you are here today. We are here for about 5 hours, and I hope that you will have a refreshing time. Thank you very much for listening. God bless us all.
Thank you. Amen.
Thank you, ma'am. So we move on to the poster presentations. So the first part of the presentation includes a number of presentations, I think like five posters. And so we're starting with Dr. Ekaite Francis Asuko on lived experiences and coping strategies of women experiencing fertility challenges in the University of Calabar Teaching Hospital, Nigeria. Can you come up, please? Thank you. Is Dr. Asuko here? Dr. Asuko. Okay, it seems Dr. Asuko is not on this call. So can we move to the next presentation, please? Thank you. Quality of Nursing Services in Public Hospitals, a systematic review by Akpan Church, Professor Ogaji, and Prof. Sonny Ikwe. Are they on the call? Okay, it seems they are also not around. Next presentation. Practice of malaria prevention among pregnant women in Oyo State by Dr. Adeniji Oluwakemi.
Thank you very much, ma.
Thank you.
Good afternoon to everyone, all protocols duly observed. My name is Dr. Adeniji Oluwakemi. The topic of my presentation, poster presentation this afternoon is practice of malaria prevention among pregnant women in Oyo State. I'll go straight to the introduction. Malaria infection is a worldwide disease that affects mostly all parts of the population in the country, and it is caused by the bites of a type of mosquito called the Anopheles mosquito. Malaria infection is endemic in the sub-Saharan Africa, which includes Nigeria, and dangerous to pregnant women, mainly because they are vulnerable at this time because of low immunity. Several researches has been conducted on malaria, and due to these researches, it has shown that health education can improve the practice on malaria prevention in pregnancy. The methodology. The study adopted a quasi-experimental type of research, and the study population were pregnant women within 2 local governments in Oyo State, Akinyele local government area and Ibadan North local government area. Multi-state sampling method was used to select 2 primary healthcare centers from these 2 local government areas. 40 pregnant women were selected through calculation of sample size and through purposive sampling from each of these primary healthcare centers. And each of these the primary healthcare center were grouped. One was grouped as the experimental group, and the other one was grouped as the control group. Validated questionnaire by public health experts was done with Chromback Alpha of 0.83 and 0.87. And these validated questionnaire were used for data collection at 3 phases during the research period. At the baseline, the second one was at the immediate post-intervention and post-intervention. At the baseline, they were given the same validated questionnaire for the 2 groups, the experimental group and the control group in each of the primary healthcare centers that were selected. And this was collated and analyzed. At 4 weeks interval after the baseline collection, another collection of data was done, which was immediate post-intervention. But before this immediate post-intervention, health education sessions were held for the 2 groups. For the experimental group, they were counseled, they were given health talks on prevention of malaria. For the control group, they were just given health talks on basic things concerning pregnancy. And this was collated to after the 4 weeks. And another data was collected at the post-intervention among the 2 groups. And all these phases, the questionnaire were analyzed, were collated and analyzed. Data were analyzed using descriptive and inferential statistics at 95% level of significance. The results. The mean age of the respondents was 27 plus or minus 1.1. At the baseline analysis, findings revealed practice of malaria prevention that there was no significant difference in the mean level between the experimental group and the control group. For the experimental group, it has a value of 11.88 plus or minus 2.29, and for the control group, 11.48 plus or minus 2.28. That was at the baseline. So there was no significant difference between the two groups. At the immediate post-intervention, there was a significant difference in the experimental group, revealing a result of 11.88 plus or minus 2.29, for which was at the baseline, and this increased to 29.43 plus or minus 1.15, with the t-value at 46.53. But for the control group, there was no significant difference. From 11.48 plus or minus 2.28 at the baseline, moved to 11.63 plus or minus 2.05, with a t-value of 1.356. At the post-intervention phase, there was no significant difference between immediate post-intervention and post-intervention in the experimental group as in the control group. In conclusion, the health education that was given to the experimental group improved the prevention practice of malaria among the pregnant women. Thank you very much for listening.
Thank you, Dr. Adeniji, for that beautiful presentation. I've been instructed to give room for just one question that may arise as a result of from the presentation. Do we have anyone with any question for the researcher? You can just raise a hand and I'll call on you. Any question? Okay. Professor Wozichi.
Yeah, thank you, the presenter. I just wanted to know if any of the social demographic variable affected the results, like maybe their age or gender, their age or any other social demographic variable affected the differences that you found in the results.
Thank you very much, sir. Well, for the gender, the same gender because they were all females. But it was discovered during the conduct of the research and the analysis that the age actually affected the practice level. But for those who have younger age, of course, it's like they don't really know the technical know-how on the practice prevention, but the health education sessions actually improved their knowledge on it, unlike the older ones. I hope
Are you
I've answered
convinced?
Yeah, thank you.
Yes, sir.
Thank you. There's an instruction for just a question, but I will indulge Mrs. Olukorede to please speak. You are not audible, ma'am. You are still not audible. You are yet to be audible. Mrs. Olukorede, we are yet to hear you. Or am I the only one not hearing her?
We can hear
No.
you.
I think it's our audio.
I think it's her audio. Maybe you probably need to log out and log in again. We actually can't hear you. Thank you, Mrs. Olukorede. Let's move to the next presentation. Maternal satisfaction with quality of midwifery care in public hospitals by Ido Gesit Udom and Patience Samson Akpan. You have the floor, please.
Thank you very much. Good afternoon, everyone. I am Idongesite Udom, just as has been introduced, presenting an abstract on maternal satisfaction with quality of midwifery care in public hospitals. Introduction. Client satisfaction is an essential component of quality of care. Akin Otiko and Otukujo, 2023. Pregnant women's satisfaction enhances compliance with healthcare recommendations. Where the women are not satisfied with care during the stages of labor, they tend to seek care elsewhere. And in the process, they come back with series of consequences, negative consequences, and morbidity and mortality rates arises. Hence, this study examined maternal satisfaction with quality of midwifery care during labor in public hospitals in Northwest Senatorial District, Akwa Ibom State. Methodology. Design. The study adopted mixed design method. For the quantitative study, descriptive cross-sectional design was used. But for the qualitative study, descriptive qualitative design was used. Population. The population of the study consisted of 2,608 women who had undergone normal deliveries in the different public hospitals. Sample. The sample size of 346 participants were selected by simple random sampling technique. Data collection. Data were obtained quantitatively using structured questionnaire based on WHO guidelines with a reliability coefficient of 0.99, WHO 2018-2016. For the qualitative study, data were obtained using focus group discussions analysis. For the quantitative study, data were analyzed using frequency counts, percentages, Pearson product moments correlation. For the qualitative study, data were analyzed thematically. Results. Participants, mostly whose age group ranged from 18 to 28 years, 48.70% perceived negative attitude of the midwives during care. Also, majority of the participants who were multiparous women, 68.41% also viewed midwives' attitudes negatively during the different stages of labor. Results also showed significant positive relationship between women's satisfaction and quality of midwifery care during labor. Also, thematic analysis of the data revealed negative midwives' attitude with reception, poor reception, and inadequate
support during labor. Conclusion. It was concluded that the study participants were not satisfied with care during labor, and it was recommended that midwives' attitudes be addressed through training. References. Thank you very much.
Thank you, Mrs. Itukesit, for that presentation. Midwives need training. Please pardon me, ma. Midwives need training on how to relate with women during labor so that they can be maternally satisfied. That's my pick. Any question? One person. You have the floor, Dr. Ayebe.
Thank you very much. Thank you, Ma, for the beautiful presentation. I understand that you used the mixed method approach for the study. Were there convergences or discordance between what you found quantitatively and qualitatively? What's the link between the two sets of data you got? Thank you.
For the two sets of data, there were no discrepancies because quantitatively, almost all the information obtained rhyme with what was obtained during focus group discussion, being the qualitative approach. They all came out almost the same reports or results. There was uniformity.
Okay. Mrs. Olukorede is with us now. Her microphone is functioning. But you are muted again. Please unmute, ma. Yeah, thank you.
Hello.
Yes, we can hear you now.
Thank God. I'm glad. Good afternoon, everybody.
Good afternoon.
Please, can you hear me now? Good afternoon, everybody.
Good afternoon. We can hear you.
Thank you, Dr. Anyimbi. Good afternoon. At least I heard your voice. The question that I wanted to ask is just for the first presenter, but unfortunately, I don't know what happened to the speaker. But just to appreciate the second speaker, once the first speaker is done with her presentation, I commend the effort of all this poster presentation and thank God for all of us that are able to participate in this. Thank you. She's done with the presentation and I wanted to ask on malaria. Thank you very much. Some other time will be okay for me.
Thank you for that understanding, ma. You
Thank
can
you.
please drop
I
your hand.
appreciate. Okay.
So the next presentation. The next presentation.
The sound is gone.
I'm sorry, I've been muted. Yeah. Ilugbaro Oluwadamilola Anyebe Emmanuel Adedibru Jibril are to present on effects of psychoeducation and substance abuse literacy among secondary school students in Ogbomoso North local government area of Oyo State. Are you on?
Yes.
You can start.
Good afternoon, everyone. All protocols duly observed. Good afternoon, everyone. All protocols duly observed. My name is Deborah Ilugbaro Oluwadamilola. I'm presenting on effects of psychoeducation on substance abuse literacy among secondary school students in Ogbomoso North local government area of Oyo State. By the way of introduction, the prevalence of substance abuse among adolescent population is fast becoming a global menace and an important community health concern. And in recent times, the use of psychoactive substances and other drugs among secondary school students appears to be widespread and relatively high. So having gone through the empirical review of psychoeducation, of effects of psychoeducation, it has been discovered that psychoeducation has been shown to be a useful therapy in psychotherapy, a useful intervention in psychotherapy and patient education. But in substance abuse, it remains seemingly unexplored. So this study decided to see the effects of psychoeducation on substance abuse literacy as both preventive and intervention strategy among secondary school students. The method adopted and implemented a group-based psychoeducational program and substance abuse literacy among secondary school students. So some schools were selected in the Ogbomoso North local government area, some secondary schools, and where this research was being carried out. We have about 5 schools selected, and the number of participants altogether were 400 participants. And it employed a school-based cross-sectional quasi-experimental design. And this is to assess the effects of psychoeducation on substance abuse literacy. Also, the schools has been mentioned there, and also convenience sampling technique was used for the study, as this type of non-probability sampling permits the use of students that will be available, because getting there, some of them were not available, some of them seems not to be interested. So convenience sampling was used so that those students that were available were used for the study. The data for this study was collected using the self-structured questionnaires to elicit the aims and objectives of the study. And the data was collected in 3 stages: the pre-test questionnaires, post-test, and the score interpretation. So a detailed structured questionnaire was used. And the data was analyzed using the statistical package for social sciences, and that's the 23rd version. And the hypothesis was analyzed using chi-square tests, and with the statistical significance of P is less than 0.05. The results, you see the pre-assessment score of the study and the post-assessment score of the study. I'm sorry, I think I sent another poster presentation, which I think there are some other things that is not here. Maybe it was not available now. In that, there is a table that shows that the result shows that there is the substances abused by the participants, commonly abused were alcohol, marijuana, the tramadol, and there are another 2 other substances. And alcohol happens to be the highest abused drug. whereas the tramadol happens to be the second abused, followed by the caffeine, marijuana, and others. And this shows that the test was scored, the score interpretation was made on 3 sections of the questionnaire, which is the knowledge on substance abuse, definition, types, causes, and reasons, knowledge on signs and symptoms, health effects and other implications, knowledge on cognitive restructuring and intervention strategies are the 3 sections which the students were scored, the score was based on. So now looking at the third table, we can see that from the pretest, the percentage was 50.78%, and the post-test shows 78.09%. Haven't gone through the record, the test scores. Now, talking about the table 3, which is the comparison of the pretest and post-test, and this is the determinant of our results. We discovered that on knowledge of substance abuse, definition, types, causes, and reasons, the pretest score shows the tests were presented, the data was presented in mean plus or minus standard deviation. And we can see that 7.8, 6.8 plus or minus 2.11 was seen as the result, while on the post-test, it was 11.66 plus or minus 1.60, which shows a correlation difference of 0.79, which is a high positive correlation difference. And you see the significant tutor, which states that it is 0.000. And this shows that there was a great effect of the psychoeducation in the substance abuse literacy after the intervention of psychoeducation. And looking at the second point, which is knowledge on signs and symptoms, health effects, and other implications, we see that the results gives us in pre-intervention test, we see that 3.24 plus or minus 1.62, and in post, it was 5.52 plus or minus 0.74, which also give us a moderate, which is 0.65, a moderate positive correlational difference, and the significance tutor is 0.00 as well. Then the knowledge on cognitive restructuring and intervention strategies reveals that the pretest is 4.32 plus or minus 1.03, and the post-test is 6.25 plus or minus 0.86, which give us a mild positive correlational difference. And this result shows that there is a great effectiveness of psychoeducation on the substance abuse literacy of these adolescent students. And the test, the hypothesis, was tested using the child test, and it states that the p-value was less than 0.000. And we all know that when the p-value is less than 0.005, it means that there is a significant effect of the intervention. And that is, so the effect of psychoeducation on substance abuse literacy is presented as we have seen, and this shows the comparison between the participant pretest and post, and with a significant increase in mean scores of all the sections. So in conclusion, alcohol and tramadol are the commonly abused substances among the study population, predominantly fueled by parental, and peer influences for the purpose of being feared and respected by others. And there was also a very good significant increase in the substance abuse literacy as seen in the students' post-test assessment mean percentage score of 78.09%, indicating that psychoeducation resulted in significant improvement in the substance abuse literacy. Also, psychoeducation program has significant effects on student substance abuse literacy. The psychoeducation program has great potential in the overall management of substance abuse among in-school youth, extending similar study to out of school may throw more insight to it. Here is the conclusion. So I want to appreciate you for this opportunity. Thank you very much, Nas.
Thank you so much, Madam, for that presentation. Do we have any contribution or questions? Just one, actually, for the presenter. Okay, for the poster presentations, we've been able to...
Sorry, I couldn't find my button, but I have a question for the presenter. Just to clarify what she meant by correlational difference while using a t-test to check for, she repeated it a couple of times, correlational difference. I'm trying to understand what's the implication of that. Thank you.
Yes, sir. Thank you very much, sir. What it means is that to know the positive correlation between, that is the difference between the pre-test and the post-test. For example, from the sections that has been extracted for our score interpretation, we discovered that on knowledge of substance abuse, definition and types, that the score was 7.68, and in the post-test, it was 11.66. So this was used when we used the statistical package for social sciences. This is what it brought out, and which gave us that there is a positive difference between the pre-test and the post-test. And that is what it means. And talking about the t-value, it's indicating the psychoeducation intervention which had a great impact on improving the substance abuse literacy of the participants. So that is why those two are there. The correlation is telling us how the strength, let me put it that way, the strength of the difference between the pre-test and the post-test. While the t-value is telling us about the intervention, the impact of the intervention on the, so all of these values are giving us that they have a very good impact, and also the correlation is a positive one, and of course a great impact, a positive impact. Thank you. I don't believe I answered that question.
Very well. Thank you.
Thank you, Prof. At least she's been able to convince you and not confuse you that there is a positive correlation. Thank you. Do we have Akman Jenny Church, or Prof. Ogaji, or Prof. Ikwe around now? If not, let us just project their presentation for our viewing opportunity. So the study is on the quality of nursing services in public hospitals. So let's see the presentation. Not this, quality of nursing services. The next presentation after this. Yeah. No, not this. The next slide.
Is here.
Oh, thank you. You have the floor. Okay. Ekaiti Asuko, that is the first presentation. Lived experiences. You have the floor, ma'am. Lived experiences.
Yes. I want to say good morning or good afternoon, everybody. I would stand on existing protocol. And I want to start by saying that June is a World Infertility Day. And I want to start by this month, June is the World Infertility Awareness Month. And so my talk relates to this month, and I will talk on lived experience of infertile women and that and their coping strategies for those experiencing fertility challenges in University of Calabar Teaching Hospital. For introduction,
pregnancy and childbirth as a proof of womanhood in establishment of. And so when a woman is not fertile, things about some psychological and physical challenges they encounter. Therefore, when there is failure to establish clinical pregnancy after 1 year of unprotected sexual intercourse, it invoked a lot of physical and strain on the marriage and the family as a whole. So my specific objective was to explore the lived experiences of women experiencing infertility challenges, and as well as examine their coping strategy. Methodology use a qualitative research approach and phenomenology as the research design. A sampling technique was purposive, and the sample size was 12 women, and it was guided by the principle of data saturation. Instrument for data collection was in-depth interview, and then the rigors ensured true credibility. Cuba and Lincoln 2005 method, which is credibility, confirmability, dependability, and transferability. And in each of them, there was that credibility. I make sure that I think the participant voice in the analysis, and then the peer review, and the other to help the credibility aspect and confirmability. Confirm that what I was actually in was the participant's voice and opinion. Transferability would reach a thick description of every research process. Then analysis with a broad thematic analysis. For my findings, the demographic variations, I actually used 12 women, and then the type of infertility, majority of them carry infertility, and then the marital status, most of them were married, and there was, it means that those that were mostly, majority of them were married, that is 7, 3 were separated, and the cause of separation was related to infertility itself, and then 2 were single. Using thematic analysis, 2 major themes emerge, and then the theme emerge. The theme 1, which was holistic impact, I had under it the physical and the mental exhaustion that is associated with the infertility. And it was obvious that when I wish I would have enough time to quote their voices and to give them enough representative. But for the physical aspect, it was obvious that most of them, when the menses comes, it was always a period of grief, because as the people grieve a child that they were supposed to have, they do not have. And then the social trauma, and I found that I was the next sub-team, the second sub-team, and then here we find out that a lot of them felt stigmatized. Infertility actually leads to a lot of stigmatization, and they are stigmatized by the public and the immediate family members. And then they withdraw, and it leads them to isolation. And then the emotional tumult and grief that goes with infertility is actually much. And then we have another team, which is the coping strategy. On that coping strategy, 3 major coping strategies were used: the problem focus, and the integrative coping strategies were used. And so, under the problem focus, and this might be the setting was University of Calabar Teaching Hospital. And so the women actually went to the hospital because it was problem focused. They used that as a coping strategy. And most of them, they said, like I quote a voice, I refuse their opinion that I am barren. With the little money I make, I decided to seek specialists, and I know I will be pregnant soon. And so that helped them. Then for the emotion-focused coping strategy, I would quote a participant voice. There was a day I felt so bad, and I did not feel like returning home from clinic. Really, it was the day my menses started. And the high hopes until it came, I had. A lady about my age saw me and we started sharing experiences. Since that day, I made friends with others. We have a lot in common and we share this together. So we both build together. The voice and make a combination of remedies that they could use, the alternative, and also supernatural intervention from God to help them with their challenges. And so I will quote a participant voice. God has the key. Although I instruction and treatment and what is expected of me, my faith is in God, who can do all things, and my story will end in praise. Now, these were some of the participants' voice, and from all indication, it actually has a lot of physical, psychological strain, and impose or invokes a lot of psychological strain on the women. But although they thought men bear the brunt, women bear the brunt, although men also share in some. But my focus was not on the men, but I wanted to see, being Nigeria is a particular society, and everything that goes with infertility is mostly brought by the women than men to a lesser extent. So it found that my study revealed a lot of strain and psychological trauma. So women face, in conclusion, women face a myriad of challenges secondary to infertility. So by addressing the psychosocial aspect of infertility challenges, nurses can improve their overall quality of life. So my recommendation is that for policy change, aim at inclusion of mental health support for reproductive health. That is where I will end my I have communicated my research findings. Thank you very much.
Thank you, Dr. Asuko. Do we have any question for her?
Hello.
You have the floor, Mrs. Olusheye.
Okay, good afternoon, everyone. And thank you for that presentation, ma. Please, ma, I want to find out, because this issue of infertility is a psychological issue. So I want to find out how are you able to assess these people and connect them with them? And also, were you able to organize the form of the briefing for them after the whole activity?
Okay, how I got them was from teaching hospital, the fertility clinic, from the University of Calabar fertility clinic. That was where I could recruit. I recruited them. I used in-depth interview. I did not use focus group discussion. In-depth interview, what I used, the principle of. So I didn't do a debriefing, because if I had used focus discussion to validate my findings, but since I use the principle of data saturation and I use rigors of Van Lincoln, which is a credibility, confirmability, dependability, and transferability, I didn't need to go back and So, but further study is actually to and support on those that are having fertility.
Okay, thank you, Ma.
Okay, thank you for that response. So do we have the last poster presenter on? That should be Akman et al. If not, let us just project the presentation. So in the next 2 minutes, we just look through so that we have an idea of what the studies are. Okay, Dr. Oluwabiodun, you have the floor now.
Me?
Dr. Oluwabiodun.
So good afternoon, good morning. Yes, please, I'm here.
Thank you.
I'll still be standing on the existing protocol, and I will be reciting the citation of our keynote speaker, Dr. Emmanuel Ejembi Ayembe. He's an associate professor of nursing science, mental health faculty at the Department of Nursing Science, University of Ilorin, North Central Nigeria, with about 24 years of experience as a nurse educator. He's currently the acting head of Department of Nursing Science, Faculty of Clinical Sciences, College of Health Sciences, University of Ilorin. Professionally, he's a registered nurse, Nigeria, a registered nurse educator, Nigeria and Sierra Leone, a registered mental health psychiatry nurse, Nigeria, a fellow West African Postgraduate College of Nurses and Midwives, Faculty of Medical Surgical Nursing, and a fellow of the African Institute of Public Health Professionals. He has Bachelor of Science in Nursing, Postgraduate Diploma Public Administration, Master of Science degree in Mental Health Psychiatry Nursing, Master of Science degree and PhD in Medical Sociology. He has over 80 published peer-reviewed journal articles, national and international, and over 60 conference invitation papers, both national and international. He also authored a book, Socioeconomic Consequences of HIV/AIDS in Traditional African Setting, which is available online in Amazon. He has participated in several studies, being the lead qualitative researcher for Bill Melinda WHO-sponsored neonatal sepsis demonstration study, 2016 to 2017, and the 2020 Bill Melinda-sponsored WHO-coordinated 6-country formatted research on management of possible serious bacterial infection during COVID pandemic. He is currently involved in many collaborative studies. His areas of research interest include nursing, health system research, mental health and psychosocial care, sociology of HIV/AIDS, mental health, psychosocial support for internally displaced persons, family health, including perinatal mental health and adolescent health. He's a reviewer for many journals, both national and international, and member of many professional associations. He was a consultant to an NGO, Women for Health, and the current national coordinator of the preceptorship training for nurses in Nigeria. He is currently the consultant to the Body-Mind Clinic of the University of Ilorin, Nigeria, where he consults for the clinic, caring for students with emotional and psychological issues. The clinic is being sponsored by a Canadian NGO, the Women Friendly Initiative. He also currently runs, alongside others, a weekly radio program titled Healthy Mind at the Uni Ilorin FM 89.3 station every Wednesday, 4 to 5 p.m., addressing various mental health issues in the community, including specific challenges of students and staffs. He has supervised 3 PhD students, over 20 MSc students, and over 100 undergraduate projects. He has mentored and still mentoring numerous younger professionals, both within and outside the nursing profession. Therefore, on behalf of the Alpha Beta Gamma Chapter, Babcock University, and the Alpha Beta Gamma Chapter Conference Planning Committee, it is a great privilege to welcome you, sir. I hereby present to you the keynote speaker of today to talk on the conference theme, Sharing Insights, Advancing Care, and Disseminating Nursing Research for the Future. Thank you very much.
Thank you very much. Let me see if I can share my slide. Can we see the slide?
Yes, sir.
Okay. Is it food?
Yes, sir.
Is there any adjustment I should do, or is okay?
I think it's fine.
Okay. So, good afternoon, professional colleagues. I'm happy to be part of this great chapter, and it's a special privilege to invite me to speak on this very important topic. And the topic is sharing insights, advancing care, and then disseminating nursing research and evidence for the future. I want to thank the hierarchy of this chapter and all the members. I think it's one of the most vibrant chapters we have in this country. And I'm sure you will have more members after this. So keep doing the good things you are doing, and well done. So I want to start with the component that talks about the future. The future of nursing globally has been a major concern of global nursing authorities. And that is why nurses and nursing all over the world have continued to focus on our future. And that was why in 2024, the theme of our International Nurses Week still captured our future with particular reference to care. And that is why I want to congratulate you again for a properly chosen, well-chosen topic. So as a way of introduction, I'm still speaking to the future of nursing. Authorities have continued to emphasize what does nursing have for us in the future. Adejimo has emphasized that when we talk about the future of nursing, we are actually interrogating how nurses' roles and responsibilities, including the education, should continue to metamorphose into meeting the needs for care. And in that process, we have to meet the needs for care. Then there will be need for advancement in all of that, because the healthcare system continues to change and it has become very complex. So in designing a path for the future, there are challenges that we must be conversant with, and the challenges are not different from what everybody in the world is faced with. And these are the 4-factor challenges that we are all conversant with. Because of time, I have 15 minutes, I was told, to present this. But let's quickly look at the complexity of the world. The world has become so complex with new things coming in, new diseases coming in, multiple decision makers are coming in, and so many things. So it's becoming very complex, and it continues to be complex, meaning that the future needs special attention. There is also uncertainty, just like there is volatile atmosphere in the world. And all of this makes the world unpredictable. So it's ambiguous. These are the challenges that we must be conversant with as nurses, that we should know that the system that we are managing will continue to change in complexity, in vitality, in uncertainty, and in ambiguity. So like I said, the focus of nursing for some time now has been on what happens to care in the future. And that's why in 2021, the Nurses Week focused again on the vision for the future healthcare. What future does nursing have for self-care, healthcare as a whole? So we continue to look into the future. We want to look at the next stages. And then that is, again, last year, we had what is called our future again. So for us, the nurses, how are we? Who are we? Where are we now? And if we want to look at the future, we'll be asking ourselves, have we actually understood this future? If we have, are we heading in the right direction? Are there enhancers? Are there barriers? Are there structures that we have that we need to use or we need to interrogate to make us head properly into the future? Are the processes being followed, or are we doing some sharp things that will land us where we are not supposed to be? Because if the processes are not followed, we are not expecting a correct destination in terms of outcome. So what are our expected outcomes? These are the things that are guiding our future. So the ICN in 2023 captures our future campaign. It was actually a campaign that was focused on 3 issues. One, for us to shine light on ourselves and decide a brighter future. That was a major campaign in 2023, last year, meaning that nurses need to move from invisible to invaluable. We don't need to hide. And that's why I quoted Professor Okoronkwo in our inaugural lecture about a week or 2 ago, that nurses are no longer the silent majority. We must be visible in the eyes of policymakers, the public, and everybody that has anything to do with delivery of care. Number 2, we also need to vision the strength that we have to change the healthcare system by addressing the demands. And that future must depend on every nurse. It's not the nurse manager, it's not the nurse leader, every nurse. And every nurse must have a voice to lead. And then the third aspect is to capture the key actions that we need to take. These actions are very essential to address the system, to address the healthcare system. And that's why here I'm saying that our group that we are speaking to today want to look at our own key action in terms of how we can disseminate nursing research and evidence for this future. And we can only do that by understanding the insights into the future so that we can advance the care. So our future is actually bright. There are so many opportunities for growth and advancement. There are opportunities for innovation, and the future and the expectations are not fixed. They are at different levels. They are hierarchical. So the future, according to ICN, has two parts. The first part that we must take seriously is that nurses are central to everything about healthcare system. Until we understand this part of our future, we may not be able to do the right things. So in terms of structure, nurses are central. They are very pivotal to whatever happens to the healthcare system. And that's why I quote here that the ICN says that our vision for the future healthcare system includes the health system that are sustainable, they're equitable, they're ethically based and fit for the future. And that has to do with people-oriented vision that nurses must key into. Then the second part is to have the vision. You make the vision a reality. So our future for nursing is that we need governments to invest in people-centered healthcare. And this vision is what should propel us in whatever we are doing into the future. Nurses are at the forefront of these models of care. So I am not surprised that your focus is how to advance care in new ways where it will work. And our focus, again, from even what I'm listening to so far in our presentations, are nurse-led. Our roles are becoming more of nurse-led than just the collaborative. So, future of nursing that we are talking about today has some critical components that should guide us. And they are already there. One is the global future of healthcare. Are there things that we can pick from there to guide our direction for the future? Then, of course, our own 4 strong directives by ICN. And finally, are there national guidelines that will help us? So we'll just look at this quickly. I won't spend time on that. But there are 6 trends currently that shape global healthcare directions. The first one is the care team, the well-being of the care team. And I ask him here, what is our status? The second thing that we must look at generally in terms of healthcare direction is the patient and the healthcare team partnership. How well are we integrating our clientele into whatever we are doing? I tell people nurses are the experts in the care system, the care environment. How much of this partnership are we doing? What is our situation currently? The third aspect is that our healthcare system in the world is becoming smarter and more connected, integrating all kinds of devices. And I'm happy to tell us, I was saying what is our status in the system. But from what we are doing, we are having conferences now, online, just like what we are doing. But we need to make it smarter. We need to make it more connected, more real. Finally, the fifth one is harnessing big data. Again, the dissemination of evidence that we are talking about. Within the healthcare system in Nigeria, how much of this do we have? Are we centrally coordinating the quantum of data that we are producing? Taking it to nursing, for instance, is there a place where nursing researches and the evidences that are coming can be put together so that somebody in Akwa Ibom is not doing something on family planning and doing another one in Zaria, somebody about the same thing? Is there going to be a way that we can harness this big data that we are having so that we can come out with designs for the future? And then the last aspect of the global healthcare direction is the distributed care. Rather than just going to the hospital for everything, you are going to the health center for everything. I think there are ways that delivery of care can be made more flexible so that the idea of this medical concept that you must go to the health center before you can be cared for can also be taken care of. These 6 components are the things that nurses key into as global directions. Now, having looked at those 6, we will go straight to the 4 directions that we are very conversant with for nursing. The nursing and midwifery global strategic directions. Whatever we are doing for our future must focus on the education, the competencies, not just the competencies, education on our attitudes, on nurses' attitudes. Then we look at jobs availability, jobs recruitment, job retaining. I don't want to talk about what is happening to us in Nigeria. The governments or parastatal agencies are saying that there's nursing shortage in Nigeria. And I've been wondering whether there has been an advertisement in any of the federal or state government institutions and they didn't get nurses. So, but these are things that should guide whatever we're doing. Of course, the service delivery, we talk about care clusters these days. How much of that are we doing? And then leadership. So these 4 areas, ICN, WHO, are great guides for our future. And I say here that with these attendant 4, we need great insights into them. And the insights will cut across the enhancers and the barriers of these 4 areas. Now, coming to the domestic level, I believe that with what we are doing in nursing, our education, the blossoming of our postgraduate studies, and all of that, the involvement of nurses in high caliber researches, global collaborative researches, like I quote Okoronkwo here, nurses' voices are being heard. And I quote her, nurses are no longer the silent majority. We have started, but there are issues that we need to reflect on. And that's why I said there are still burning insights that are still built. What are the other evidences that we are working? How is the support from our regulatory body, our professional bodies, and specialty bodies? These are areas that we need to look into. So a few things that are enhancers for us that we can key into and we should be reflecting and researching into is how well our over 70% of health force as nurses being useful to us. Of course, we are hearing now that we are no longer the silent majority. We are not silent, but how loud is the voice? How willing is the nursing population? The increased demand for nurses, how have we keyed into using it to improve our system? These are the insights I'm talking about. Then part of the enhancers too are the technological advancement. I am happy virtually every time I open my internet, I see what we call nurse-led care models, churned out internationally, nationally. These are things that are enhancers for the next level of nursing that we are talking about. So the role of nurses continue to expand and continue to extend. And this creates insights for us to lead. So if we want to advance care, then we cannot stand still. And I want to tell us that what happens in Nigeria now, in most of the areas that we are looking at, we are not standing still. But are we harnessing all that we are doing? this kind of conferences, what will happen to the data that we are going to discuss? But there is need for us to continue to advance constantly. So most of the efforts that we consider for this kind of advancement will have to be interrogated because they are criteria for the health outcome that we desire. Now, globally, the desire of the population is for us to have quality health outcomes. And one of the central issues in terms of discussing health outcome is access to care. That is what everybody is talking about. So if you have the best of care and it cannot be accessed, then the outcome still remains poor, non-existent. So to advance care, therefore, access to care, it should be one of the things that we'll be reflecting on. And that's why, again, I want to congratulate us that this title, Research and Evidence, which are the key components of achieving high caliber client care, it is very welcome. So I am saying that for us to research and provide evidence, it means there has been some kind of insights. And that's why I want us to look at what really are insights that we are going to share. We must understand the insights. Then we find a way or ways of sharing the insight. But it has been established that there is increasingly lack of insight in so many organizations and groups, including our own healthcare system. Some of the things that happen in our public healthcare system will make us think that, are we having leaders who have insight into the organization, into the groups that are within the organization? So with all the kind of exposure, intellectual, professional exposures we are having, things don't seem to be that we have insight into our problem. What some people would call, there is an illusion of knowledge. The knowledge base should be there, but people don't seem to present the insights. And so we found ourselves drowned in huge data, but poor insight. And that turns our information to useless intelligence, so to say. So if we have the information, we have this quantum of data, and our insight is poor, we will be wondering where the data came from. So lack of a shared definition of insight, for instance, seems to be the major problem. So a common understanding of what insight is or what is not seems to be a major problem. And as well, the absence of the methodological rigor that we need to present and generate insight remains also a problem. So you see organizations, you see our systems, our health systems, our educational systems, sometimes all the social systems struggling to do what is right, probably because the insight is not standardized. Now, basically, all of us have clear idea of what an insight is, but it would be fair that I define insight. Simply, it will just mean looking inward. But there are more things to look outside the inward. So there are several definitions that exist for insight, which we have just summarized here. The three that I have here, one says that our ability to perceive clearly and deeply any situation is insight. To clearly perceive whatever that is happening to us. Somebody simply calls it a penetration into issues, a penetrating and understanding of complex situations and problems. Insight is also our capacity not to only understand ourselves or the inward thing we are talking about, but to also understand the outside, the processes that happen outside, the understanding of an event within and outside. In this case, within nursing, within the healthcare system. So if we have that ability to understand ourselves, we also need to understand the outside. That is what an insight is. Now, insight, for you to say that it's an insight, means that you need to visualize the insight so that it will like form a powerful activating part within the system. So you have to imagine the issues that you are talking about as springboards from which we are going to emerge. So there are issues like how might we, statements that we talk about. So if you reflect on issues, one of the things that will come out of your reflection is how can we, how might we? And that question will lead into the future. So insight is not casual observation from what we have said. It's not just knowing. No, it is a creative reflection into complex situations, events, and actions. And that kind of insight requires some skills. One of the skills is creativity, persistence, and deep thinking. You will need, you don't do it just, it's not a one-time exercise. Okay, so much for insight. Insights are actually originating from the knowledge base, knowledge that is analytic, knowledge that is critical, knowledge that is in-depth. So for us to understand insight and share the insight, then we need what we call both system and client insight. System here will include healthcare system, educational system, religious system, all the social systems that we have. And of course, our client, be it not individuals, family, groups. Insights that we get from this group will help us to form a kind of lighthouse for the future. I have something on the other side showing that you need to turn your knowledge into insight. If we just continue to gather knowledge and we are not looking critically into the knowledge and interrogate the knowledge, then our insights will be poor. And then the future may not even exist if we don't have insights. So basically, I'll just glance through this. There are 5 principles that define insight. 1, you need to understand the context. Simple observations, critical observations of the context that you operate within. And most times it is going to be holistic, a structuralist kind of approach. Having understood the context, if you have to now critically look inward, look outside of the issue, then you may communicate something that looks like a dilemma. A dilemma occurs around values, behaviors, needs. Dilemma because there are things to do, equally good things to do. How do you determine which one to do? Again, that leads us to why most people go into what we call the ethnographic studies. Because for client experiences like the lecture or the presentations I've heard, I've listened to some lived experiences. That is what is happening. What is in an individual cannot be brought out by basic qualitative study or quantitative rather study. The lived experiences, the lived community experiences will bring out issues that you may not exist in literature. And when you pick those things, even if it's in one person, it will lead us to articulating for the future. So you now articulate the why, an understanding of why those things are there, those unmet needs and all of that we need to reconcile. Then we key into the motivation and envision the ideal things to do. It is only when we apply these principles to insight definition that we'll be able to say, okay, the insight we have created can be shared. And the insights that we can share I just have summarized. Literature showed so many insights that we can share from the perspective of nursing and from the perspective of the healthcare system. One, do we understand the nature of nursing? Do we even understand the nature of the healthcare system? So our insight should look in this direction. Remember, the definition of insight is first inward. And so we are starting. Inward here will mean healthcare system and then the nursing system. There are diverse issues that need critical exploration from our research approaches and all of that. Another insight that we need to look at to create events for the future is the demographic transition that we are experiencing now. People are living longer, and if people are living longer, then we should know the kind of care that we should be preparing for the future. Luckily, Nigeria seems to be understanding that, and we have just started a program in gerontology nursing in Benin. That is like looking into the future. Is that enough? Another insight that should guide us is the epidemiological transition that we are also seeing. Epidemiological transitions are issues related to our populace. There are a lot of changes in our lifestyle. We want to live like some clients where the system tolerates certain things and we want to live like them. And that has implications for us, the care that we give here. Again, the socioeconomic and lifestyle originating from this epidemiological factor is that people's feeding style, eating style, activity style, lack of patient-centered approach, rates of unaddressed access are becoming huge. We need insight. What about creating awareness in these areas? What about the structural issues that are responsible for poverty in Nigeria, which has direct impact on health? How much of it have we understood? There are societal, structural things that are making people to be sick. They are making people to lose their brains. They are breaking down mentally. What about the processes? How well do we do things? So we need insights. These are insights that we need to create for most of us that are lecturers, for most of us that are postgraduate students, for most of us that are nurse leaders. These are the things that we need to throw at our younger ones to look into because of the future. There are other things, the universal coverage, the issue of advocacy, the issue of policy, and the issue of multi-sectorial engagement are all issues that we need to share insights on. Now, if we are able to share insights in all of this, then we will know that to advance care is actually a multifactorial engagement. And what I have here is that there are a lot of them, a lot of these considerations that we have to do. Number one, like we have said, great insights in and outside of us, great researches that we have to do, and then the potent evidences that we are going to generate. So if we talk about care, we have 4 factors when we are talking about access, the coverage which WHO is focusing on so much, the services themselves, the quality of the services, the timeliness, and then of course the workforce. All of this must be there for us to say that the quality of care is not just good, but it's also sustained. And if they are sustained and good, then we have to improve the access. So the access that we have to interrogate through our insights into are usually based on some issues. How much of established guidelines are we using? Protocols, best practices in our community, in our climate, when I say community, I mean the healthcare system. When it suits some people, they will mention best practices. When it doesn't suit them in terms of distribution of hierarchy, they will tell you this is Nigeria. Is that how our quality of care will be sustained? So regardless of wherever patients are, we need to adhere to some basic best practices. And this will lead us to improved outcome, satisfaction, like I have heard some of the presentations done, and effective use of healthcare systems. So global standards are very important so that we can help our policymakers, we can advocate, we can plan with the planners, and then we as professionals can also use this information to implement things that we need to do. There are these 4 components: evidence-based, patient-centered, monitoring and feedback, and safety. We'll go further because there are other things to say about that. Now, if we want to advance care, because we know that everybody seems to be living longer, they will suffer from more chronic diseases, then we must have insight on how to detect and treat these diseases. And we have to focus on the way we fight diseases. And one of the ways that we can fight diseases is to recruit people to help us collect information that will help us to take decisions. And we do that by helping researchers on finding ways to prevent, to detect, and to treat. And that's why I say here that we can do this by generating and protecting the data that we generate. And this data that we generate has to be stored and managed according to the standards. Now, the issue of disseminating the research and the evidence for the future will guide the kind of things that we do. Research as a systematic investigation helps us to generate insights. On the other hand, the evidences that we get also will help us to all take decisions because there are proofs. So in terms of hierarchy, where I will not waste our time, the relationship between research and evidence is very clear. Research will help us to generate the evidence. The evidence, when interrogated, may take us back to more research. And so they continue to act like the chicken and the egg, which one comes first and all of that, okay? The research informs evidence. Evidence uses research findings. Evidence identifies research needs. Research needs or research evaluate evidence. So it is that cyclical. But when evidence is not there, or the evidence that we have is not enough, we are saying that we need to conduct research. And I will not say much about that. But the relationship between the two can be captured like this. While treatment choices not only depend on the outcome, it also depends on the experience of the clinician and the preferences of the people we are caring for. And that is the guide to how research can be utilized. As you see in this circle, I'm sure this material will be shared. So what I have just said is what is simply called the tripod of evidence-based practice. The three strands are the best evidences, the clinical expertise, and then the patient preferences and values. This should guide us. Again, what will guide us, which I want us to pay a little attention to without much discussion, is the models. There are models, several models for guiding evidence usage. The Iowa model is there. The ARCC model is also there with their specific assumptions. Then the Johns Hopkins model is there, and of course, the Stettler model. All of them are similar in function. What I mean is that there are steps that you have to take to be able to do. And all of them focus on these basic core principles. We need to be asking questions into the future. Having developed insights in all the areas we have talked about, ask questions on the population. Ask questions on the intervention. Ask questions on comparing interventions. Ask questions on outcome. When you ask this question, then you access the best evidences that exist. You appraise the evidences, apply them to see, evaluate the outcome of the application, disseminate the information, and maybe to take us back to ask more questions in a cycle like this. Like I have said, is cycle. But when you identify the problem and you get the evidence, and the evidence makes sense, okay, explain that sense in two directions. Is there a need to update it? Look at the evidence again. Is it poor? Is it good? Do I go further to apply the evidence? These are the things that we are talking about. So going towards the end of what we are discussing, sure, I'm taking more time now. We will be asking ourselves, at what stage of evidence gathering are we in Nigeria? What is the level of our research? What is the quality of the data that we are getting? Are we still just doing descriptive studies? Beautifully, I listened to studies today, mixed method. Are there translational implementation demonstration studies that we are doing? I'm sure we are developing models, because most of our PhD students are developing models. But what is the hierarchy that we are churning out? Are they based on our insights, or we are just sharing or churning out evidences in partial fulfillment for the award of certificates? Have we been interrogating what ICN is asking us, the economic power of care? So this, all of us are conversant with, are the hierarchy of evidence. And we know that the base is the weakest, while the peak is the strongest. Where are we? Where are our studies focused? Are we focusing on the peak, or we are still at the base or somewhere in the middle? And you know that the base towards the middle are not strong. So if we want to do research, we should head towards the top. And you know what? When we look at this hierarchy, for professionals like us, hierarchies will help us to look at these things. Remember, we provide care in terms of therapy. We provide care in terms of prevention of illnesses, like we are getting the aged more. We also try to look at prognosis. What are the issues causing the problems we are having? What are the diagnoses? This slide is showing us that for us to interrogate hierarchy, if we want to interrogate therapies, those are the things we look at. The peak, systematic reviews and meta-analysis, randomized control trials. That's where we can pick evidences for interventions and therapies. And then it goes down like that. If you are going to look at prognostic indices, for instance, you do not need randomized trials. You take cohort studies of diabetic patients who have diabetic feet and want to find out what is the outcome, things like that. So this aspect of hierarchy addresses where we should look for information to care for our patients. And because this is very important, our key issue is how is this research and evidence disseminated? Why? We have reasons why. It will help us to access the latest best practices. It will drive quality improvement, which this conference is focusing on. It will also help us to reduce errors and promote patient outcomes, promote quality of care, improve long-term, short-term, middle-term outcome, and ensure that patients are treated in the best ways possible. So when we are disseminating evidence-based information in nursing, then we will need to create a culture of continuous learning and collaboration. And that is where our nurse leaders come in, all of us. We need to encourage nurses to share their experiences and research findings through the different means that we know, some of which are our oral presentations that we are doing now, publications, and then social media, electronic media. We need to disseminate this information in these ways. And that requires a number of strategies. Teamwork, you will notice that most of the studies are multiple authors. Collaboration is one of the best ways that we can go. But some of the other ways is just basic storytelling, share your case studies with people, with your colleagues, the environment that you find yourself, make it very learning, very conducive for learning, use interactive virtual simulations like we're doing, and engage opinion leaders and leaders, clinical champions that we call. You have to include them in the process. Otherwise, whatever we are presenting will not fly. Then we have to carry ourselves along. There are other methods. We need to act as agents of change. We need to provide the right resources, the right leadership, the right role playing that we need to do. We also need to employ what we call a planned change. A lot of us are resistant to change, and we have to apply the principle of unfreezing. You move and then refreeze so that we can move further. And then, of course, the theory of diffusion of innovations. Create awareness. They may resist it. Persuade them. If it doesn't work, you are in charge. Take decision. Plan your implementation and go ahead and confirm. Tell them that, look, what we have done is wonderful. There are other strategies that we have mentioned here. However, in all of this, there are barriers. And the barriers, as we already know, we don't need to waste time here. There are both institutional, interdisciplinary, and intradisciplinary problems. Nurses may be the problem to themselves sometimes. But if you look at this is a study by some group of nurses who are looking at what health professionals see as both enhancers, depending on how you look at it, or barriers. The training and educational support, if they are there, it becomes an enhancer. If they are not there, they become barriers. Attitudes, this is the same way. The consumer evidence, the same way. Logistics, the same way. Institutional support, policies, and access, depending on which way you look at them, can be barrier or enhancer. So to summarize this opportunity, we are saying that insights must be identified and shared. And evidences that we generate will provide diverse frameworks for us to advance care, if we must tailor what we are doing to specific clinical settings, ensuring a systematic approach. Most times, our nurse leaders are very busy. They may not have all the time to appraise the evidences that they need, but we can do certain things. One, we can build a workforce that is fit for the future. And that is our responsibility, all of us. Number two, we need to restore and renew the reputation of our profession across. And how do you do that? You need to be on top of your game. Your ignorance of the latest finding is not an excuse. So we must be connected to where we are specialists, so that as new information is coming in, it's hitting straight on your handset, on your laboratory, on your laptops. And I'm sure a lot of us have Google Alerts connected. So we must be on top of our game. We must not be speaking discordantly. You are saying this for nursing, and somebody will say the direct opposite for nursing. That is not good for the future. We need to look at some trusted sources when we are looking for information. The right people, I continue to emphasize the right processes. Shortcutting in terms of research, shortcutting in terms of providing evidences will not make sense for us. Then the system transformation, the right culture, like I've mentioned, the right leadership, the capacity to interpret and understand evidence, and engaging the staff and patients where needed are very, very important. So in conclusion, if we must practice based on evidence, then we need models. These models throw our minds to insights. It opens our mind to things that we may not see ordinarily. The postgraduate studies we are saying we are doing, please, we need to work on a model where our postgraduate students don't come to the school to look for topic on the shelf. They should come after identifying a problem to solve. That is insight. It is not after your coursework, you now start meeting your supervisor for topic. That is not a good frame of insight definition. So also the need for us to talk about quality, high quality care that is scientifically sound. In other words, they must be researched into and the best available evidences, meaning that our researchers must step up to the higher level, like I have said. And then all nurses need to share what we are discussing. I don't know how we are going to do it. I don't know how many of us are here. We are less than 100. How do we share this insight with others so that we can key into the same future? We have been called to raise the bar. And that is, we need to read nursing. We need to understand nursing. We create insight. We acquire the skills to create insight. We acquire the knowledge and skill to create evidence. We acquire it to also understand and use the evidence by reading. We also do that by assessing the evidences we have. There are protocols for care that we also need to interrogate. The protocol that exists came about from evidences. If new evidences go against protocols that we are using, let's not say it is the protocol. Let's contemplate on what it means so that our care can improve. Then we need to integrate these sound evidences to practice in every setting. As simple as how relevant is bed making by nurses? By nurses, I tell people that in the mental health setting, for instance, if you go to the mental health setting and you see bed making by two nurses, it's an aberration. Bed making in the mental health system can be by a nurse and a patient, or even two patients. So we need to build certain sound evidences into every setting, as basic as that could be. And then we need to share the insights that we have talked about, and encourage others to help us share the insights and then work towards creating the evidences. At the end, then we will be excelling. So finally, there are motivators and triggers and barriers. We need to enhance the motivators. We need to embrace triggers. Triggers may be things that we cannot change. And so if we cannot change, we deal with them. We live with them and overcome them if possible. The barriers can always be overcome. That is the Unilever's model of instructive change behavior. Where do we stand? Are we still on the traditional approach? Or are we refocused on insights that will direct us to researches and provide evidence? Where do we stand? In the training of our postgraduate students, are we creating insights in our lecture? The nurse leaders, are we creating insights so that we can advance the care, so that we can do the researches that will produce the best available evidence? Thank you very much for your time.
Can we send emojis for clapping? That was a very, very, very good presentation. Thank you for mind-boggling us. Thank you for helping us to reflect. Where do we stand? Where do I stand? That was a very interesting, challenging, motivating presentation. Thank you so much, sir. and God bless you.
Yeah, I need
So,
to unshare, right?
yes, we move on to the next programs we have, and on our program. Oh, I'm trying to locate. Okay, we are going back to, or shortly before we go back to our poster presentations. We have Mr. Ademola. Yes, Ademola is now around. Can you please say something to us?
Yeah, good afternoon.
Thank you for joining us.
My colleagues. Hello, can you hear me?
Yes.
Yes, we can hear you.
Yeah, thank you, President. Good afternoon.
Okay, so it's time for questions and answers. Do we have questions for Dr. Ayubi? Anybody with questions? Please raise your hand if you have questions for him. No questions. Are we ruminating? Are we trying to know where we stand?
Oh, they didn't even hear me at all.
Ah, they did. We all did.
I have a question. I don't know. I raised my hand.
Okay, might be the network. I didn't see that. Okay,
Oh,
okay, yeah,
okay.
you can go on.
Yeah, that was a very beautiful presentation, Dr. Anyebe. You really stimulated our minds. Now, talking about sharing insights and also advancing care, I don't know what your thoughts are on the issue of emigration of nurses, because most times we see it as on the negative side and often neglect the positive side. Now, are there any positive area that we can harness from our nurses who have left the country or those who are still going to leave the country? Are there positive areas that we can harness in order to help our country to share insights and also to advance practice? Because there are evidence-based, researches that have shown positive impact of this phenomenon in other countries. But what are your thoughts in this regard within the context of Nigeria? Thank you.
Thank you very much. Probably because of time for emphasis, you must have noticed where I mentioned issue of collaboration across, locally, internationally. I think most of us should be aware that we have this North American group of Nigerian nurses who have been impacting on nursing in Nigeria. They were to have a national conference in the year 2020. Some of us had already submitted abstracts before the COVID came. And as we speak, we also have what we call the Forum of Nigerian Nurses and Midwives in the UK. I'm privileged to be part of the board of trustees. Now, these are people and groups that are doing wonderfully well. When I was presenting, I said, Nigerian government is saying that some of the things happening to our nurses not being allowed to verify, go out is because we have nursing shortage. Is that true? Is there anywhere, I don't know if you know, that a federal government hospital or a state government hospital or any standard hospital in Nigeria advertised for nurses and didn't get? So how are we defining a nurse shortage? So I am not one of those who look at exploring what is happening outside as negative for this country. There is always a lot of positive aspects to it. Unfortunately, also, there are some negative aspects because most times it's even the best trained, the best brains that leave this country. So, my brother, I believe there are a lot, and we can talk till tomorrow on the positive aspects. So there are so many. There are so many. However, while we are being drained, some people are gaining because of what we are also saying. I talk about our systems. Our systems have a way of not taking care of what we have. And as professionals, look at the footballers. You may not be able to tie them down to a club because they have what it takes. That's what we are facing in Nigeria. So there are positive signs. Apart from the repatriation of cash, repatriation of skill, I have enjoyed training from Professor Adegoke in UK. I told you I was, or the person that read my resume said I was consultant to Women for Health. It was through a classmate who is in UK and coordinating over from there. So there are a lot of advantages, okay? Not negatives as so much as people are portraying it. Thank you.
Thank you, sir.
I see many hands.
Yes, there are so many hands. We are stimulated. Mr. Ademola Shafiu.
Thank you very much. Good afternoon, Prof, for this beautiful presentation, sir.
Thank you.
I really appreciate. Yes, sir. You're always our teacher, and we appreciate that. First, I want to say that thank you for changing my own, let me say, assumption that we don't have shortage of nurses in Nigeria. The moment you said it, I look around, I said, wow, listening to lectures will really make you to know the difference between fact and fallacies. And I really appreciate that. And that is one major thing that I gained today. Sir, to my question, you have talked about the issue of insight. I want to ask, do you think, what is the role of welfareism in gaining insight? Do you
the
think
role of
that,
welfareism?
Yes, welfareism in gaining insight. Do you think that the working condition,
yes,
remuneration for nurses in Nigeria will allow us to have insight into development, research, real research, on sort of real research and communication of research? Because I think that a comfortable mind will think rightly. What do you think is a correlation with that, sir? Thank you, sir.
Thank you very much. The problem that you have just mentioned should even create more insights. And this is what I mean. Why is the system so nonchalant about the welfare of people? That should even spur us to studies. I talked about structure, I talked about processes, and I talked about outcome. I just didn't want to mention the owner of the model, which all of us know. The structure is our social structure. And I continue to insist on structural and process engineering. I mentioned those two words. Our structure is such that we don't seem to focus on what we should focus. And even when we do, it's just on paper. When it comes to the processes that should take us to what that structure stands for, we don't seem to do the right things. That's why I was talking about processes. Yes, If you want to do very good study, you must have all it takes. And I can give you an example for some of us that are in public universities. For 2 weeks, I may not have light in my department. It's as serious as that. My salary, I don't want to mention it in the public domain. But when I'm submitting my paper for final chair, they are expecting me to have scopus publications. In fact, Q1, Q2, Q3, Q4. Where do I generate that money from? And you want to use it to measure my output. And you are not, I don't even have the data to look for information officially in my office. No power to use unless I create for myself. So that is how bad what you are saying is. But the issue is, when we are talking of insights, these problems we are enumerating should also make us to begin to ask questions of the why statements. Why is our structure like this? Why do people jump protocols, procedures? That's the process now. And then what is the outcome? The outcome is what we are seeing. People are leaving. Even as you say you are not verifying, those who have crossed are now working as nursing assistants because they don't want to come back. And the Nigerian system, if they understand, they are the ones losing because your citizen that you have so trained is now working as a nursing assistant when the person can pass their exam with one attempt. We are shortchanging ourselves because the process is faulty. So those are the things that should even create more insights. The question you are asking invariably is, how do you undertake quality studies that will give you the kind of evidence that we have? That is a big challenge. But the problem should create more insights. The why, and the how questions. So this is where we find ourselves. The good thing is the same people that are outside are the same people that are sponsoring some of our studies that we're able to do quality study, not our own system. Why is that so? More insights. So, Demola, I think our present predicament opens more opportunities for more insights, more studies, and the more of why, both structure and the process, as well as what we are getting as outcome. I don't know whether I tried to answer your question.
Really, sir, you really do justice to it, sir. You did. Yes, sir. Thank you, sir.
Thank you, sir. I'm sure he's not confused any longer, other than keep thinking. Professor Showumima, you are recognized. You raised your hand, ma. But you raised your hand.
No.
You raised your hand, ma. Would you please talk then? Thank you.
I will drop.
Okay.
Good
Professor
afternoon to everyone.
Wozichidi,
Good afternoon to everyone.
Oh, okay. Good afternoon, ma. Professor Showumima, your hand is still raised. Mrs. Bojubola, you have the floor, please.
Thank you very much. Our keynote presenter. I don't know whether you can hear me.
Yes, very clearly. Good afternoon, ma.
Good afternoon, sir. Thank you very much for that powerful presentation. Firstly, I want to thank you because while Dr. Oluwabiodun was reading your resume, something struck me, and that's the fact that irrespective of what the system is like currently in Nigeria, you have decided to make impacts. You run a radio program. You also have a section where you, through an NGO collaboration, where you try to make impacts and take care of the mental health of your students and the community at large.
Thank you, ma'am.
That's the challenge to me, and I'm so grateful that had you well. I had that's been read thoroughly. My own question is this:
yes.
Though I would say it's you have tackled it to some extent, but I'm looking at it. You have challenged us to go back and share the insights.
Yes, ma'am.
But I'm wondering, how can we do this, especially in this current prevailing economic situation in Nigeria? I work with the states. Currently, I'm not going to say this in the public, but the nurses are on strike. And I try to engage my people. I say, can we just look for some evidences that we can bring on the table to the policymakers? Because you need to argue your points. It's not a matter of fighting. But if you can present evidences, okay, like for example, I was saying, okay, nurses are going. Can we have some things to say that, okay, if we can do A, B, C, D based on this study, I think we can retain some of those nurses that are going. I know that some of those policymakers, because I am privileged in a little bit to move with some of them, they reason with evidences. But how are we going to do this with our current prevailing situation? Maybe if you share with us how you've been able to do yours, because you're also in the system. Thank you very much, sir.
Thank you very much. I think you have even handled the same issues that you are raising. The issue of finding ourselves in the kind of situations we find ourselves. It is very difficult to convince people to say, let's do a research when the person is struggling to buy fuel for the car to come to work. It is very difficult for you to say, come, let's sit down after work so that we can spend some time, brainstorm, and agree on the way forward in terms of evidence generation. They are very difficult situations. What has helped us, that I continue to say, is collaboration. If you see some of our CVs, you will see even Q1 journals where we have published. It is not from us. It's not from our salary. That's what I mean. It is because we're able to collaborate with some big people. So to say, big people, not the policy. So I want to still advise us to look outside our immediate environment. The biggest things that are happening now, I think some of the professors on the platform will tell you that any proposal that you have, just dress it very well and keep it by the side. One day, you will just see something thrown like similar to your own. Look for some 2-3 people and send it. Even if it is $1,000, you start from there. That's collaboration. Now for the home, Ma, you are very correct. You cannot convince anybody with stories that this thing is like this unless you present facts. We are short. We are short. How short are we? Are you able to present how many we were 5 years ago, nursing the same number of patients, and how many we are now? You make it, not, you know, administrators don't like reading big English. Just on a page, from so year to so year, we were 100 in this hospital. Maybe the bed space then was even 50. Now you have expanded the hospital beds to 150, and we are now 30. Simple. That will show how short we are. We no agree. I've told people, there's nothing like we no agree. Throw data at people. And some of these things are not difficult to do. For some of us that have been exposed, is it possible to work with our heads? I mean, heads of nursing, to say, let's project what is happening. Hello, ma'am. Hello?
Hello, sir. I can hear
Okay,
you,
I'm not
sir.
sure whether
We can
people
hear
are
you,
still
sir.
hearing me.
We
Okay,
can hear
okay,
you, sir.
okay. So the structural and economic situations are making things difficult for us. But like I have said, motivators, triggers, and barriers, we must face them. If not, we will not be able to puncture ourselves into that future that they have tried to barricade from us. So let's collaborate. That's the first thing. And let's speak to as many people as possible in terms of the insight. Out of 10, you may be lucky you have 1 or 2 that will key into the insights we are presenting. You don't need more than 2 people to generate good evidence. And if you have, please interrogate your evidences with others. I share an example with you. There is a study we are doing now. I don't know where the money came from, with Kano and Bauchi, and I think Sokoto. And somebody, a PhD student that we were co-supervising, wrote the systematic review of his work. And somebody saw it somewhere, and he said he was interested and started giving some money. If he didn't make an attempt to push that systematic review, he would be in the cooler then. So we still have to just try to do something from our corner. You were asking how I'm doing my own. The way I'm doing my own is collaboration. All the WHO work that I did is not with a nurse. It's not even with a mental health person. It's with a pediatrician. He's a professor of pediatrics, and I saw what he was doing, and I told him, look, I am a qualitative researcher. Is there any space for me? And they said we should submit an application. He sent it to WHO. Somehow, God favored us, and I was picked as the lead qualitative research. If I didn't talk to him, I won't even go there. So let's keep, trying. And I think God will favor us. But sincerely, it is a very serious system that we find ourselves. No data, no light, no nothing. Thank you, ma'am.
Thank you so much, sir.
Thank you.
Professor Nwozichi, I need to collaborate with you.
Yes.
I'm a quantitative researcher.
I'm very open to collaboration. I'm looking for all the people on the platform for us to collaborate in the little ways that we are working.
We'll start sending messages to you, sir.
Thank you. Now, I just saw one of our students that is in US on the platform. He just sent a message, and I was at Lawan. Lawan is from Maiduguri, and he recently got scholarship to US. Those are the kind of people that should also help us to link up. Lawan, if you are there, make sure that you link us up, talk to your people there, and see how we can key in. We have very beautiful areas to study. I'm sure all of us on this platform, we are researchers. So if you have such, just let us know. Lawan, thank you.
Yeah. Hello, Dr. Imde.
Okay.
Thank you, sir.
I'm back home. I'm already in Nigeria. Thank you so much for the presentation.
Oh, you are back.
Yes, I'm back home.
Make sure you keep the links so that you can next year when we are doing presentation, we want to see a collaborative work between your people over there where you went and some of us here. That is the way to go.
Yes, sir. Yes, thank you so much. Advice taken.
Thank you. So organizers, take notes. Follow him.
Duly noted, sir.
Yeah, welcome back.
So
we have noted it. Thank you.
We move now. We should actually go on a 5-minute break, but this is 2:27 already, and we have a long way to go. So I have been instructed by the committee that we should continue. So in that vein, we will be moving on to the second part of the poster presentations. And we will start with We will start with Salako Omolabake Fetiat. We will be presenting on patterns and determinants of CAM usage among pregnant women in Shagamu, Ogun State. Is Salako on the call? You have the floor.
Yes, hi. Good afternoon, everyone. I'm standing on existing protocol. Salako Omolabake Fetiat, and I'm presenting my abstract on patterns and determinants of CAM usage among pregnant women in Shagamu, Ogun State. So I'll begin with my introduction. And we have here that many pregnant women continue to utilize comprehensive alternative medicine in the management of pregnancy despite potential maternal health risks. And this shows that in most communities, despite the advancement of orthodox medicine, we still find women who utilize CAM practices such as Apha medicine, spiritual healing, acupuncture, natural supplements in the management and sustenance of the pregnancy and their born child. So moving on to the objective. The objective of this research was to explore the patterns and determinants of CAM usage among pregnant women in selected primary healthcare centers across Shagamu State. So now moving on to the methodology of the study. For the research design, we utilized a descriptive cross-sectional design for the research, and the total population of pregnant women from both primary healthcare centers was 168 pregnant women. And for our sample size examination, we used Taoyamin formula for known population, and our sample size was 130 respondents, and which were randomly selected from the 2 selected primary care center. So here we have for Africa Primary Care Center, selected 19 respondents, and from Sabo Primary Care Center, selected 111 respondents. And for data collection, we utilized an online survey through Google Forms, and the demonstration was interview-based, meaning we asked the questions to pregnant women and we recorded their information on the Google Forms. So next year, we have for the analysis of the study. For the quantitative analysis, we utilized the statistical package for social sciences, the version 26. And for the hypothesis, we utilized the chi-square test. Now, swiftly moving on to our results / findings of the study. Now, here for the mean age for respondents, it was with 7.6 plus ratio of 5.6. And when we look at which were the most popularly utilized CAM practices among these pregnant women, we found that the highest was natural supplement, which was 8.5%. Then prayers, which falls under spiritual healing, was 86.2%, and herbal medicines falls under 83.8%. And these 3 were highlighted as the most popular and most utilized CAM practices by pregnant women's population. Then for our determinants, we discovered that the major determinants of complementary alternative uses among this population, the first was culture and religion, which was 50% of respondents. Affordability, 50% also, and we had accessibility, which was 7.7%. Now this shows that these 3 core factors, which we have religious factors, we have the cost of these practices, and also have are accessible as these practices to them within the communities. So these 3 are highlighted as the major motivators or driving forces to pregnant women utilizing CAM practices during pregnancy. And then for the hypothesis, surprisingly, we found that there was a significant association between antenatal care by midwife and CAM usage. So we found that pregnant women utilizing midwifery care for their antenatal services increases there's an association or relationship between that practice and the practice of complementary alternative medicine among these respondents. Now, finally, to our conclusion, first we have that CAM usage is prevalent among pregnant women in Shagamu, with diverse patterns and moderations driving these choices. And also, we also advocate for tailored intervention to address the potential risks associated with uncontrolled CAM usage within the population, because we realize that most of these pregnant women did not really know the negative impacts of utilizing these practices during pregnancy. So that will be all. Thank you very much for your time.
Okay, thank you, Ms. Salako, for that presentation. So, do we have any question for her? Just one person, actually. Any question or we move on? I hope I'm audible here. Okay, in the absence of none.
Can I ask?
All right.
Yeah, I see in her result, I see in your result that you said that there was a significant association between antenatal care by midwives and CAM usage. Maybe you want to interpret that. Does it mean those who are being cared for other professionals do not use, CAM, or what exactly does that area mean? Thank you.
All right, thank you so much for your question, sir. So regarding this, during our data collection, for this particular question, we had series of other healthcare professionals such as physicians, nurses, and midwives to know the care they get during pregnancy or who they go to for their care during pregnancy. And out of these options, the one they used the most was midwifery services, which were midwives. So upon the analysis, we discovered that women who are actually their first primary care or contact for midwifery service was midwives. They had higher chance of receiving CAM usage in this research within these respondents. So I hope that answers your question, sir.
Yeah, and it's interesting though.
Thank you, sir.
It is interesting. Thank you. The next presentation. Next presentation will be on determinants of cervical cancer screening uptake among women. Determinants of cervical cancer screening uptake among women by Oluwatosin Rosemary Oyeleye and Patience Edo Samson Apha. You have the floor.
Good afternoon, sirs and mass. I'm Oyeleye Oluwatosin Rosemary, and I'm here to present determinants of cervical cancer screening uptake among women. And this is being carried out in Lagos State. So as we all know that cervical cancer silently claims lives of women due to non-utilization of the screening exercise. And this research was conducted to assess the determinants of uptaking cervical cancer screening among women of reproductive age in Otuawari Local Council Development Area in Ojo Local Government Area in Lagos State. And the study adopted cross-sectional survey with multi-stage sampling to select 440 women of reproductive age, and the data it was analyzed using descriptive statistics and hypothesis tested with Pearson product movements correlation. And from the result gotten, it was discovered that majority of the participants had poor knowledge about cervical cancer, and also most also had poor awareness of cervical cancer screening, and this had led to poor uptake of the screening, which we can see the percentage to be 12.9%. And the main determinants that was discovered, they are lack of awareness of cervical cancer screening. That is, they are not aware of that screening for them to make use of it. And out of those that are even aware, there is fear of unknown, that they don't know what will happen after taking the test, what the result will be. Then there are cultural belief too, and also societal influence from friends, from family members, disallow them from obtaining the test. And from the hypothesis, it was discovered that there was no significant relationship between the knowledge of the cervical cancer and obtaining the screening, which means that if they are aware and in the process of creating awareness, their knowledge about cervical cancer can be improved, and this can encourage them to uptake the screening. And also, there was significant relationship between the awareness of cervical cancer screening and uptaking the screening, which means that if they are able to get proper awareness of this screening, it will enlighten them the more on what cervical cancer is, the danger it poses, and it will help them to know that we need to uptake the screening. So as the presentation is the presentation of the results is in pictorial form shows that 20% they had good knowledge about cervical cancer, which means we have 80% that they did not know more about cervical cancer, which is one of the reasons why they are not even getting aware of the screening services that is available for them. Then we have also the frequency that is showing that the poor awareness, that is 62.5%, they are not aware of this cervical screening service, which make them not to uptake it. Then the table is showing us that only 12.9% are already screened for, which is very low, and is one of the problem that Lagos State is facing, because they do put up free cervical cancer screening for women and they are not making use of it. And they are making all efforts so that they can make use of it. Even last year, they trained around August 2022, they trained some professionals and they make sure that they have the knowledge to attend to women. But this uptaking is the issue. But they are improving gradually. We like 53,000 are now uptaking it, but there are still problem with the vaccine. They are not yet getting awareness of that vaccine, and some they have this traditional belief that is one of the strategies for government to kill people to reduce population. So the conclusion is that there is poor knowledge about cervical cancer. The awareness is low, and it affects the uptake of the cervical cancer screening. So there is need for more awareness so that they will make use of the opportunity for them to screen and then reduce the effects and the complication that cervical cancer poses among women in the community. Thank you. Hello?
The light just went off in Babcock community, and we hope that the light will come up soon. So if the presenter is not within the confines of Babcock University, please continue. Thank you.
I'm done. I'm done presenting.
She's done.
All right, thank you. So do we have any question for her? Okay. In the absence of none, we move
I
to the
think
next.
somebody is raising her hand. Tanko Tiauta.
Okay, you have the floor, please. Tanko Tiauta, you have the floor. Your hand is raised. I think it's an error. So let's move to the next presentation. Clara O. Lawal, outcome of information communication technology literacy training on nurse educators' adoption and usage of multimedia teaching aids in Ogun State schools of nursing. Please come up, ma'am.
Good afternoon,
you are muted.
everyone. I think I've unmuted myself. I didn't realize I was muted. Can you hear me, please? Right. Can you hear me?
Yes, ma, you're audible.
Okay, thank you very much. This research was done some time ago, and of course, like our keynote addresser said, we leave it and then, but this time I thought it's a good opportunity to bring it out. So there might have been some changes since I did this research. The research was on information communication technology. Are we using it for training our nurses? Because I am an educator and I have been working for some years. And I think I've noticed that, yes, we may not actually be using it. So I got to look at training the educators and finding out whether we use these technologies in teaching. It was a quasi-experimental study, and it was conducted in 4 schools of nursing in Ogun State, and the old nursing school that we have at that time. We have any participants that was using educators. I don't know how many teachers we have in our schools. Okay, at that time that it was the time that they were recruiting new nurses, and so I had about 20 to use for my experiments in the 4 schools. Structured here was used to collect, and I data on the availability, ICT. I also accessibility of ICT. I looked at passive skills, passive ease of use, and finally, I looked at adoption and usage and of multimedia. I looked at it in the experimental group. I looked at it in the control group. Now, what did I do? I gave training using a researcher designed training, which I designed by myself, and it was validated for me by my lecturer and people from education department. And there were 3 modules. There was information technology, there was nursing information, PowerPoint presentation, and also the nursing aspect of it. Now, the lectures were given on 3 weekly basis for 4 weeks, and the other control group were just given time to look at traditional teaching methods. Frequency counts I used to look at the availability, and the mean scores per group were obtained and compared. I tested some hypotheses and used students t-test. Now, what did I find? I found that majority of the participants were female. I think I had maybe 1 or 2 boys, and that was men, sorry, and the others were female. And most of them were the nurse educators cadre. If we understand the nurse educators cadre, it means that they were the lowest level. And we have senior lecturers, then we have and then we have the other cadres. But most of them were of the lower cadres because they were nurse educators cadre. Now, computer and projectors were the most available out of all the other ICT this thing that I wanted to find out if we had, and only 2 of them were available. There was significant increase in passive skills in the experimental group, which suggested that the increase was as a result of the ICT training. There was also significant change in attitude in both groups. there was also significant increase in the usage of multimedia aids at the end of the research. Now, my discussion and the conclusion. When we looked at the number of ICT that were available, we found that they had maybe 2 in each school, and they were kept in the office of the HOD, or what they call the principals. So if you needed to use it, you have to make sure that you either have collected it, or you have to tell the HOD. And most HODs do not want these things to get spoiled. So I found that the accessibility to these projectors were not really very available. And the computers, there were just a few that we found in the library. Some people will have about 14, and the most that I found was about 20. And that was not really enough for the number of students that we have in the school. But the other aspect was nurses' reluctance to use this technology. Even though some of them have this, the 2 projectors, but then they prefer to dictate notes or to let the students get the notes by themselves if they use the lecture discussion method. Therefore, that was also not good enough. But I found that even though people may say that nurses were not computer literate, but almost all of them were computer literate, except a few. And of course, those were the elderly ones that when they were in school, of course, they didn't have computer. It was only 2021 that it was actually included in the curriculum. But before then, people were doing it outside the nursing curriculum. So, but now it is there. And so, 2005, 2003 was when it was included. So, but now I think every one of us, we are all computer literate, if not very, very deep. But the few ones, the young ones, are really good now. So what are the challenges that confronted they are not having enough? Many of them were because the government were not interested in making sure resources were available, as in most places in Nigeria. But then the most important thing is that we ourselves, we must always be able to get across to government using our research and using our research results, evidence to show how we need these things. Then we also have electricity challenge. In the schools, when I was doing my research, I had to go with my generator and with my own instruments that I needed to do the research. Because when you get to schools, they will tell you should give money for us to buy petrol or diesel or whatever. So, but the fact that electricity was not available was what I found that was the most inconvenient thing for use of these resources, apart from the fact that the number that were there were not enough, and apart from the fact that it was really not very accessible. So, Nursing and Midwifery Council, I think, when they are doing their continuing education, should include the fact that they can do some of continuing education in this area for the nurses, so that they will not forget what they have learned. Nurses are very busy, but now technology is what is being used all over the world. Globally, it is what is being used. And so our nurses too should get to this stage and be able to use these resources. Because if you travel, then you have to start learning first. And that is why many times they say our nurses must undergo 6 months training or 6 months whatever before they can do anything. The state governments too, for each of the schools, should not only be concerned about making money and for themselves, but that they should be concerned about giving some of these resources that are needed. Same thing with federal government institutions. They should also be able to do this as well, so that the resources can be available in the schools of nursing, which are owned by the federal government. Private universities are, better than many of the other schools because the students pay a lot of money. So because of that, in a way, they are able to provide, especially those that are coming in, the new private universities, they know they have to provide these facilities for these students. And I know that since I've worked for some time in Babcock University, that ICT is readily available. Throughout the COVID period, the school was on, and many schools, many other schools of nursing could not continue even at that time. And so we know that these private universities, they are trying, but at the end of the day, in conclusion, everybody should try harder to make sure that nurses that are being trained are properly trained using the ICT that are available, even though they're in short demand, but at least they should still try. Like we were told, there are many things that are not available. There are many things that we are struggling to get, but at the same time, educators must ensure that they get into the global village and use some of these facilities that they can get online or which they can collaborate with other people to get. Thank you very much for listening.
Thank you, ma'am, for that presentation.
Oui.
Do we have any questions for her? Any question? Okay, let's move to the next presentation. Symptom clusters, symptom burden, quality of life in breast cancer survivors. Rotobo D and Nwozichi CU.
Good afternoon, all. Good afternoon, sir. Good afternoon, ma. Please, I hope I'm heard. Good afternoon, everybody.
Yeah,
I'm
you're
presenting symptom clusters, symptom burden, and quality of life in breast cancer survivor. Now, the question that needs to be asked is, breast cancer survivors, are they really free? That's the question that is historical. And that's what brought about this work. And a scoping review was done. Breast cancer is a global health, is of global health concerns, and is estimated to have up to 2.3 million new cases yearly, and more than 6 conditions seems to be life-threatening and associated with so many symptoms and distress and asked just now, breast cancer, are they really free? They are survivors. They've had chemotherapy, they've had other treatments, but are they really free? Now, the symptoms experienced by these cancer patients tend to coexist. That's where the symptom clusters come in. And these symptom clusters tend now to increase the burden of these patients. They might be free from cancer, but from the treatments and the treatment modality they have had, are they really free? So this tends to, due to the effect of the symptoms and the symptom body and the treatment plan the patient undergo, there have been a huge impact on their quality of life. And now it seems that quality of life experienced by these cancer patients affect they comes in emotional, psychological, physical, and social functioning. It's been identified that the symptoms body affect their quality of life. And now that we, the health care provider, what do? Now we know that actually they might be free from cancer, but the symptoms they experience, are they really free from the burden? So now this will now help to tailor proper symptom management. And that's why this scoping review was done, in order to know the different and then make a comprehensive treatment plan. In this scoping review, several articles were reviewed. Gotten. Several databases were assessed. We used the Scopus, PubMed, Science Direct, Science Web of Science, Google Scholar, or getting developed inclusion and exclusion criteria. Some of the inclusion criteria were patients have to be above 18, papers have to be viewed, and the objective of those studies have to be in line with what the objective of the study we're carrying, that's of our scoping review, and the paper has to be in full test. Now, after using the Prisma, thematic analysis was done in the 19 papers that were finally included in the study. And what did we find? The results. It was found that patients experienced physical symptoms like fatigue, endings of hair, and these symptoms were within the range of moderate to severe burden. And this body tends to increase with intensity. Psychological symptoms were identified. We saw high level of anxiety and worry. We have disturbed sleep, and we saw low self-esteem and depressive symptoms. Now, Joe, we talked about the symptom cluster. It was seen that physical symptoms, psychological symptoms, emotional symptoms were coexisting at the same time. It was found that psychological symptoms had huge symptom burden on the patient, and this aggravated the physical symptoms they were having. For some patients who reported lack of sleep, they had higher level of depressive symptoms, and they had exaggerated fatigue and pain because of lack of rest. So it was, and the effect of the psychological burden on the physical symptom now reduced the quality of life that was reported. However, two different stated that their patient had good sense of coherence, while the other studies show that their patient had good, those that have good self-efficacy had high quality of life. Now, then the other paper that showed the good sense of coherence, they said those patients that had good high sense of coherence had better quality of life. Now, what can we get from this? It was now drawn from the study that patients with good sense of coherence and good self-efficacy would have better quality of life. And this is where the study had drawn its conclusion that health workers should strategize means to think about other determinants of health instead of looking at the physical symptoms. Look at those other symptoms that could aggravate one symptoms. Look for a symptom that could aggravate the other symptoms, and look for ways to manage those symptoms in order to improve the quality of life for this cancer patients. And now we now said that the presence of a complicating symptoms like emotional, psychological symptoms had huge impact on the physical symptoms, and this directly affects the quality of life of breast cancer survivors. Therefore, what do we do as healthcare nurses, as healthcare providers? We should pay attention to other determinants of health that could cause higher symptom body on quality on the breast cancer patients, thereby improving their quality of life, so that at the end of the day, those patients who actually said they are free from cancer, they have undergone chemotherapy, they've undergone surgical management, they've undergone radiotherapy, or even the endocrine therapy, could still have a better quality of life after undergoing those treatments. Thank you very much.
Thank you, Mrs. Brotobo.
Am I still on?
Yeah, you are on. Thank you. Any comments, any question for the duo of Brotobo and Uwozichi?
Yes. Yes, thank you. I just want to appreciate the presenter. The researchers have done a very good systematic work. I'm only concerned, I want to know which type of studies were included in this systematic review. Thank you.
All right. Yes, we are waiting for the response.
Sorry, maybe I can ask my own so that she can answer the thing together.
All right, ma'am.
Thank you so much, the presenter. Please, how many articles are you able to review before you analyze your data? Thank you.
I don't know if she's still here. Maybe I can answer some of the questions. The article, the articles, well, I can't remember now because I'm just doing an oversight of the work. But they were much, but then we had to use the Prisma
I'm here, but it's breaking. I can't really make any sense. Hello?
Can you hear?
Please go ahead.
Can't really, is breaking.
Okay, let me just answer the questions. So we use the Prisma guideline to eliminate the unnecessary ones. So we restricted the review to full text articles that were within the objectives of the study, and then abstracts were eliminated. So at the end of the day, we were just left with only 19 articles that met the criteria. So I'm not sure of the full, the initial, review, the initial downloads that we had, but then eventually it was 19 that was left that met the criteria. So this also answered the first question that was asked, the type of articles we use. They were full text. They were relating to the concept of symptom clusters, symptom burdens, and how they relate to quality of life. So, and then it's restricted to the last one was to 2023, and we couldn't get any article for 2024. So that is just about it.
Okay, sir. Thank you so much for the response.
Thank you so much.
All right, thank you.
Actually, the question I referred to was to define the type of study that was included in this review, whether they are randomized controlled trial studies, or they are descriptive studies, or they are all types of studies that we have combined?
Well, all type of studies were combined, but there is no intervention in this case, so we didn't really get randomized control trial. These were more of descriptive and correlational studies. Thank you.
Okay, all right, thank you so much.
All right, thank you. Let's move to the next presentation. Okay, Botidem Anedi Udo et al. On caregivers' environmental sanitation knowledge and practice to prevent children's diarrhea. You have the floor, please.
Please permit me to stand on existing protocols. My name is Botidem. I'm presenting on caregivers' environmental sanitation knowledge and practice to prevent children's diarrhea. The high prevalence of diarrhea in the southern part of Nigeria is a public health concern, and previous studies associate diarrhea to environmental sanitation. Therefore, this study aims to explore caregivers' knowledge and practice of environmental sanitation in preventing diarrhea among children in Ikorepele and the local government area, Kwara State in Nigeria. Methods. A concurrent triangulated mixed method design was used for this study, where the qualitative aspect was a descriptive cross-sectional survey, and the qualitative was exploratory design. The sample size was determined using Cochrane's formula for the quantitative to recruit 300 caregivers, and for the qualitative, saturation method was used to recruit 15 caregivers. Sampling procedure for the quantitative was a multi-stage random sampling without replacement and proportionate sampling. For the qualitative was purposive sampling. Data collection instrument was questionnaire for the quantitative, and in-depth interview and observational checklist for the qualitative aspect. The validity and reliability of instruments was ascertained using first and content validity for the quantitative, and a reliability score above 0.7 was obtained using Apha method for the quantitative. Then for the qualitative, it was a first validity and trustworthiness of the research process was ensured using the 4 aspects of trustworthiness by Lincoln and Guba, according to McCarthy and Fitzpatrick 2019. Then the method of data analysis for the quantitative study were frequency, percentages, chi-square test, and multi-logistic regression. And for the qualitative data, it was analyzed thematically. The results, out of 300 caregivers, 216 representing 72% of them had a good knowledge of diarrhea, 271 had representing 90.3% had adequate knowledge of environmental sanitation, and the key environmental sanitation barriers included poor state of the facilities and time consumption. Hypothesis testing reveals significant influence of demographic characteristics of age, marital status, education, occupation on knowledge of environmental sanitation and diarrhea prevention. A significant association between knowledge of environmental sanitation and practices for preventing diarrhea. There was a significant association between knowledge of environmental sanitation and practices for preventing diarrhea. Qualitative analysis identified 3 major themes: the rehearsals for diarrhea prevention, barriers to environmental sanitation, and facilitators to environmental sanitation. And 13 sub-themes emanated from the analysis. In conclusion, caregivers demonstrated a good environmental sanitation knowledge and practices to prevent children's diarrhea, though I did not have a 100% response. Key words were caregivers' knowledge, environmental sanitation, children's diarrhea, prevention of diarrhea. My references are there. Thank you for listening.
Thank you for presenting. We appreciate. Any question? Any question? No. Okay. I think we have one more presentation. Let me check the program. Oh, okay. We have another lecture. That is all. We have come to the end of the part 2 of the poster presentations. Thank you to every presenter, and thank you for contributing to the field of nursing. We move on to the next lecture, which is Empowering Nurses in Hospice and Palliative Care in Africa, to be delivered by Miss Omolabake Salako. She's a Senior Nurse Research Associate of the Nosology Academy. You're welcome, Madam, or Miss. Miss Omolabake Salako. Is she online?
Hello, hi.
Hello.
Good afternoon, everyone. Can you hear me?
Yeah, you're audible. Thank you.
Good afternoon, everyone. Good afternoon, sir. Ma'am. It's such an honor to be here to make presentation. And I'm going to share my screen. Okay. Give me a moment, please. Okay. Can you see my screen now? Hello. Please, can you see my screen?
Yeah, the title of what you want to talk.
Hello.
Your screen is on.
All right. Thank you so much for that, ma'am. So once
I hear
again,
you.
okay, so once again, good afternoon, everyone. I'm really honored to be here. And this afternoon, we're talking about something that is really, really important in nursing, and yet it has little or no emphasis in our current practice. So the topic for today is empowering nurses in hospice and palliative care in Africa. And as I was right to introduce, I'm Omolabake Salako. I'm the Senior Nurse Research Associate of Nosology Academy. Okay, all right, thank you for sharing my screen. Thank you. All right, next slide, please. Hi, thank you very much. So for introduction, we have globally, the need for compassionate end-of-life care is rising, especially with the high rates of cancer in our population currently, especially in Nigeria. We have high cases of cancers erupting across different population. So that means there's a need of more intensive and more centered end-of-life care for these patients. And you may ask, what is palliative care? Well, according to WHO, we have palliative care is an approach that improves the quality of life of patients, both adults and children, and their families who are facing problems associated with life-threatening illnesses. And life-threatening illnesses will include cancers. And now, according to definition, we can see that there are three focuses here. We have quality of life, we have the patients, and we have the families. So palliative care and hospice is centered around these three elements of people, which the patients themselves, the quality of life of these patients, and their families, because their families are heavily involved in end-of-life practices. So next slide, please. So if you're wondering what is the difference between hospice care and palliative care, now, according to what we have here is palliative care is provided alongside curative treatment, while hospice care focuses solely on comfort measures with an expectancy of 6 months or less. So hospice care is typically for patients who are already very close to death, and they have maybe less than 6 months to live. But whereas palliative care is given to patients that are very ill, but they still have a longer period of time to live compared to patients for hospice. But at the center of both hospice and palliative care, we have a very key term, which is comfort. Hospice care and palliative care aims to bring comfort to the patient, and not just the patient, also to bring comfort to the family members that are also in charge of the care of the particular patient. So next slide, please. Now, when we look at the global view of palliative care, it is very surprising to find out that 56.8 million people are in need of palliative care every year, but only about 14% of people currently receive this. This shows that we have lots and lots of people who desperately need comprehensive end-of-life care in the healthcare practices, but it's very surprising that only very few of these people actually receive the care that they deserve. And now, according to what I wrote there, nurses are uniquely positioned to bridge the gap and ensure more people have access to palliative care. Personally, nurses are at the forefront of healthcare services. Nurses are everywhere. Nurses are anywhere. And when it comes to end-of-life practices, we nurses are the ones that are there from the point of care to the point of death. So I believe that we nurses, we are perfectly positioned to bridge that gap and ensure that more people have access to end-of-life services which they desire and sometimes even deserve, because when we look at hospital care, it's not just patient-centered, it's also family-centered, and it also has huge benefits for even the nurses themselves who are practicing these types of care. So next slide, please. Now, this is going to be a very interesting concept, and this is the death culture in Nigeria. I don't know if we know this, but there is a death culture in Nigeria. I'm sure we must have experienced it in our practices, we have experienced in our daily lives, but maybe we do not know exactly what it is called. And this death culture is how we as Nigerians view death, or how we as Nigerians respond to death. And according to what we have here, Nigerians traditionally view death as a part of life journey surrounded by family. Every typical person will tell you that they would love to, die at the comfort of their home, have the family members around, to have that kind of reassurance of they have lived a great life and they have lived a great family behind. So, and we also view death as it's like a terminal part of life. We are born and we also die. So it's more like two polar opposite ends. And then we find our culture and religious beliefs influence end-of-life care in Nigeria, including respect for elders and spiritual well-being. So when it comes to the death culture in Nigeria, we'll find out that in many settings, let me cite an example. For instance, a patient that has been terminally diagnosed with brain cancer, and even if the doctors and the healthcare professionals tell them that, okay, this is a terminal disease and you have just 6 months left to live, we still experience the fact that family members still go out of their way to seek help. It may be spiritual help, it may be going to other hospitals, it may even be traveling out of the country just to seek more curative treatment for this patient, even after being told that the patient does not have a long time to live. And this is a part of our culture, and this shows that it's hard for us as Nigerians to accept the reality of death, especially when it comes to our loved ones, because we do not want the person to die. And instead of facing the fact the person is to die, most of us would want to do our best to ensure the person lives, even at the expense of the person's comfort and the person's choice for peaceful death. And now, all these perceptions and all these misconceptions and all these values and beliefs of Nigerians really, really affect how they accept the topic of hospice and palliative care. Because, for instance, if you're a nurse taking care of an end of life patients, and you're telling the patient to the family members rather to enjoy the time they have left, and while you'll be working on ensuring the patient has comfort and ensure peaceful passing for this patient, you'll find that some family members would not really accept that, because they do not want their loved ones to die. They want to do whatever it takes to ensure that their loved one survives the crisis. And sadly, even after running around, going to different sources, seeking spiritual help, the person still dies. And that person would have lost the opportunity to experience a peaceful death. And peaceful death is one of the core principles of nursing, according to Bashir Anderson's definition of nursing. So next presentation, next slide, please. Now, I mentioned there because this is how I like to view palliative care. Palliative care is a bridge, especially in the Nigerian setting. Palliative care should be seen as a bridge that helps you to honor traditions and respect the cultures of your patient while still providing modern medical support. Because we have diverse cultures in Nigeria, especially we have the Yorubas, we have the Igbos, we have Hausas, and each culture has their unique perspectives of death. Each culture has traditions that they uphold when it comes to issues of death and passing. So as a nurse, if you are in that situation of having to provide end of life or hospice or palliative care to your patient, you must also know that these traditions exist, and finding a gap, being the bridge between honoring traditions, honoring what they want, and also ensuring that you're providing medical support towards ensuring that patient has peaceful death. Next slide, please. So now we have how hospice and palliative care support families. We have 4 ways highlighted here. And the first way is relieve burden and stress. Because to be honest, when you have a loved one that is terminally ill, it's always very stressful on the family members to care for that patient. But when you as a nurse can come in and provide that care, it's most often relieves them of the burden and stress, knowing that you as a nurse, you are there and you're providing the care for their family and loved ones, and also providing them that comfort they need at that terminal stage in life. The next one is improve communication and understanding. When we as nurses provide palliative care, we support not just the patient, but also the family members, in a sense that we can always talk to them. We can counsel them, they can ask questions about things they may not be aware of, we can guide them. Through this communication understanding not only helps the family member, but also helps the family member how to also care for their loved one that is terminally ill. The next one is grief support. Okay. The next one is grief support and bereavement services. Like I mentioned earlier, during palliative care, also to provide, counseling to this patient, help them to process grief, because most often grief doesn't start at the moment the patient dies. It starts before the moment the patient dies, during the palliative or hospice care. So you are also to help to anticipate grief, and also help to navigate the process of grief when it happens. And the last one is peace of mind. It's very important, or actually, I think to put myself in the situation of a family member whose loved one is going through hospice, I think it gives the person a peace of mind, is knowing that my loved one is going to pass in a peaceful way. My loved one won't have to suffer, won't be in pain, would have as much comfort as necessary to ease their death, to ease their passing. So I think that peace of mind is very, very important for family members, knowing that their loved ones died in a peaceful manner and a loved one died comfortably. So next slide, please. So next slide we have is the barriers to palliative care in Africa. The first one is limited awareness and education. Well, when it comes to limited awareness and education, I won't say it is, yes, nursing students are taught about hospice and palliative care as part of the curriculum during the undergraduate days. I was taught, but I think when it comes to the application of hospice and palliative care, we don't really find that in most of our clinical settings. So we have here that most of them, and once we don't apply them in our clinical settings, that means that the families of these people actually needing this care do not have access or do not have information about these services, because it's not a common practice in Nigeria. We don't, most times the families are not informed of the options of palliative care and hospice. So that limited awareness, that limited information already rules out the opportunity for the person to have hospice or palliative care. And the next one is medication access. Now, during hospice care or palliative care, most of the most important interventions, pain intervention, especially for cancer patients who are usually in severe pain when they're terminally ill. And there are some regulations in Nigeria that kind of restrict or inhibit the access and administration of these medications. And also, there are also misconceptions from the side of the public regarding these medications. So all of these things create difficulties and create challenges when it comes to actually providing hospice care in Nigeria. The next one is resource constraints. Most hospitals in Nigeria do not have the resources needed for hospice care. And when I mean resources, I mean have trained nurses that can provide this care, have the equipment needed for this care, have the medication needed for this care, have the infrastructures needed for this care. And all of these things really affect the process of providing this care, and even affect the opportunity for patients to be provided with this care. So resource constraints are a very big factor when it comes to providing hospice and palliative care in Nigeria. So next slide, please. Now, when it comes to the core principles of palliative care, we have 3 core principles. The first one is pain and symptom management, especially when it comes to hospice. When it comes to hospice, patients undergoing hospice, they are terminally ill and they usually experience loss of symptoms depending on their disease condition. For example, if it's cancer, they usually experience pain, fatigue, and other symptoms relating to their illness when they're terminally ill. So one of the major goals and principles of palliative care at that point is to ensure that this pain and these symptoms are alleviated, because the goal is to provide comfort for these patients, and a patient cannot feel comfortable if pain and other symptoms are present. So that's why one of the first core principles of palliative care is to ensure that pain and other symptoms that the patient develop are well taken care of through nursing interventions. The next one is psychosocial support. Now, this is very, very important, because the patients themselves too will be undergoing some psychological challenges and difficulties internally to accept what is going on with them, to accept the possibility and the reality of death happening to them way sooner than they expect. So we nurses, as providing palliative care, need to be there and offer psychosocial support in how the patients deal with this anxieties within them, and also how they address anxieties to their social groups, such as families, such as friends, such as co-workers, such as every person within the social capsule. So it's very important to provide that social support so the person can easily navigate the process of hospice or palliative care. The next one is spiritual care. For instance, if the patient you're caring for palliative care is a Christian, it's very important to be conscious of the fact that the person would want to be closer to God and will want to do things or perform spiritual activities towards end of life. It's very normal. It's a very normal psychology when you're about to die and you just want to have a stronger faith, and you want to be closer to God because you believe you'll be going to him very soon. So it's very important to also take part in the spiritual activities and not ignore them, but also take part in the spiritual activities, and with limits, and knowing when it's right to do it and when it's not right to do it, and simply guiding them during that process. Next slide, please. So next slide talks about what are the core skills for a nurse in palliative care. The first one here is effective communication. This is very, very, very important. And effective communication goes in diverse forms. Effective communication is not just to the patient. Yes, you have to communicate properly with the patient. You have to understand bodily cues. You have to understand the patient's emotions, both verbal and non-verbal cues for effective communication. But also, effective communication also involves you communicating the interventions, the processes, the activities to the family members of the patient, and also to other healthcare professionals, because when it comes to palliative care, it's oftentimes an interdisciplinary collaboration. It involves you, it involves the physician, it involves social worker, it involves different healthcare workers. So you must also be able to communicate the processes and the activities and interventions and results to every key player in that collaboration. So the next one is cultural sensitivity. In Nigeria, being the context for using here, in Nigeria, we are very cultural sensitive and we have traditions. Some people have traditions that they always adhere to. So it's important to be aware of these traditions. It's important to also know how to navigate these things when they arise. For instance, let's say Yorubas, we usually tend to use agbo frequently. And let's say your patient wants to use agbo. So maybe your patient family brought agbo for the patient to use for maybe to alleviate pain. Now, as a nurse, you need to know how to interfere in matters like that. It's not just about you rejecting. You can't actually reject the family from providing help to their loved ones. You have to know how to be cultural sensitive. And that cultural sense will also help you to how to teach you or help you in communicating to the family members why the patient doesn't need what the Apha concussion have been brought to them at that point in time. So it's very important to be aware. Cultural sensitivity involves you being aware and being knowledgeable about the cultural identities of your patients in order to facilitate enhanced care for them. The next one is emotional intelligence. Emotional intelligence deals with you recognizing non-verbal cues in both your patient and your family members. And when it comes to end-of-life care, emotions are typically high, especially from the family members, because it is not a pleasant experience for both parties. So emotions are very high. A family member will come to you and be angry, and that will just be their own way of processing grief. So you have to be emotionally intelligent to know how to handle that anger, and it's not by responding to them in a way that would set them on fire or make them more angry. It's about responding to them in a way that they know that you understand where they're coming from, and you help them to also process their own feelings and process their grief and process all negative emotions that are coming along with the process. So emotional intelligence is very, very important when it comes to managing end-of-life patients during hospice and palliative care. The next one is teamwork skills. Like I mentioned, hospice care is typically an interdisciplinary collaboration in this with different healthcare workers. So you must know how to work in unison with them and ensure that everything being done is for the betterment of the patients. So you have to do this in sync, in synergy, and all members need to be informed of anything that happens to the patient and all the interventions and all the progressions regarding the patient's care. The last is life closure skills. And life closure skills is very, very, very important indeed, because typically at the point of death, there are high chances that the nurse will be present at the point of death. And at the point of death, typically patients may have wishes, patients may have things to tell their family members, patients may even have things to tell you as a nurse that has cared for them throughout the whole process. So it's very important to have life closure skills on how to, process the process or navigate the process of the patient's life finally ending, because this has impact on the patients, the family members, and even you as a nurse who have cared for the patients all through that period. So it's very important to know how to navigate that process of the patient finally letting go of life, listening to the patients, being there, ensuring the family is there, and ensuring that whatever the patient needs for the person to be as peaceful as possible is present. Next slide, please. The next slide we have is empowering nurses in hospice and palliative care. Now, like I mentioned, in Nigeria, hospice and palliative care is not common. It's not an opportunity that is afforded to many patients. Many patients die without opportunity of actually experiencing hospice and palliative care, actually experience that comfort of peaceful death. So what are the ways we can use to empower nurses towards hospice and palliative care? The first one is increased education and training. When it comes to increased education and training, it's it typically starts at the undergraduate level. It typically starts by teaching students about hospital palliative care, giving them the knowledge they need so when they face that in clinical setting. But also when it comes to clinical setting, because that is where it actually happens, there needs to be workshops and trainings for nurses in clinical setting towards understanding and managing patients that need hospice and palliative care. And also specialization programs need to be implemented in Nigeria that focus on providing hospice and palliative care for patients. And that will be very, very key to ensuring that the end of life process, the end of life stage of patients is peaceful, is comfortable, and it also focuses on quality of life, which is not usually so in most healthcare settings in Nigeria. The second one is mentorship and role models. Now, for this part, when it comes to even being there at the ending moments of patients, it is sometimes emotionally draining for nurses. It's very emotionally draining because it's a patient you have cared for maybe for a short time, maybe for a long time, but there's usually a connection between you and that patient. And then when a patient passes, their emotions would definitely erupt because we are human beings as we are nurses. So it's very important to have right mentorship, to just share our feelings with fellow nurses, to talk to them about the experiences that we've had, to also hear down the experiences, also have tips and recommendations from them to how to handle the process better. And also learning from established programs and best practices across the world and having them being implemented in hospital settings across Africa really help nurses in better navigating the process of hospice and palliative care. The next one is networking and collaboration. Now, when it comes to hospice care, I think I mentioned this before. Hospice care and palliative care doesn't involve just the nurse, it also involves other healthcare workers. And it's very important to have that relationship with other healthcare workers towards enhancing palliative care. Because if we don't have that relationship with other healthcare workers, it makes the process of palliative care more tedious because there's no synergy between the key players of that team. And when there's synergy between the key players of that team, in the long run, it affects the care of the patients. So it's very important to have good collaborations, good relationships with the members of your team, and even build relationship with healthcare workers that are involved in palliative care towards learning from them and also improving your own practices towards palliative and hospice care. And also the last but very, very important is participating in research and development initiative. In Nigeria, there are very scanty researches done about the process of death, done about like hospice and palliative care. And I think we really need to do more research about this topic because it's really, really enhance the end of life stages of patients and especially towards providing comfort care and also towards providing peaceful death for these patients. So we need to participate in more researches and more development initiatives towards improving and enhancing hospice and palliative care in Nigeria. Next slide, please. Okay, there's a slide before this. Okay, so what we have here now are actionable steps for nurses towards hospice and palliative care. These are things you can do on a daily basis in clinical settings towards ensuring or providing hospice and palliative care to your patients. The first one here is initiate open conversations. Now, talking about hospice and palliative care to your patients or to their family members is not often how should I put this? It's not often the best of experiences because it's a very sensitive issue and requires a lot of emotional intelligence to approach the issue. So you have to gently approach the topic of end of life care with patients and family. Converse with them. Talk about it to them like you understand them. Because once it feels like you are not understanding them, then there's no synergy in the conversation. It really affects the possibilities of them accepting end of life practices. So you have to gently approach the topic to patients and families for them to explore the option of end of life care. The next one is to offer resources and information. When talking to them, you can always offer resources, offer insights, offer examples of how this care can be effective for the patient and even them, like the family members themselves. The next thing is to advocate for patient choice. It's very, very important to advocate for patients in every setting, especially during end of life care. We have to know that they have to enlighten, is our duty and also enlighten these nurses, not enlighten patient and family members about the option of hospice and palliative care, to know that they have this information, and having this information means we're empowering them to make the right decision they believe would be for their family or for their loved one that actually needs care. So also when you're advocating for patient choice, you have to also be informed about the patient's cultural and religious preferences. You cannot assume that the patient would want it. You cannot assume that the patient would tolerate it or accept it. So you have to be conscious of their cultures and their religions and how that may affect the possibility of them accepting end of life practices. The last one here is compassionate presence. Now, nurses need to be compassionate at every point in time. We are champions of compassion. It's very important for us to sometimes put ourselves in the shoes of the patients or put ourselves in the shoes of the patient's family members in order to really understand where their grievances may be coming from. So it's very important to be able to provide emotional support to them through active listening and empathy, because having a loved one or having a family member that is terminally ill is not an easy experience. It's a very challenging period for them. So you have to be able to provide emotional support, listen to them, and most importantly, be empathetic while listening to them, so they can easily, be receptive to the opportunity or to the option of them being given end of life care. Now, to offer comforting presence during difficult times, sometimes a patient, for instance, maybe the points at which the patient is told that they're terminally ill. Nurses, we need to also know that.
I'm sorry to interrupt, Ms. Salako, but I'll give you just 5 minutes more. I'm sorry to interrupt.
All right, thank you so much. So it's very important to be able to provide compassionate care during difficult times. So next slide, which is the last slide. So the last slide is a call to action to all nurses. Empowering nurses palliative care is very crucial to improving end of life care in Nigeria. And I'm sure that doing that, we can all ensure that patients and family members facing end of life situations in Nigeria and across Africa can receive the support they deserve towards, we're providing comfort and towards ensuring that these patients have the opportunity to experience peaceful deaths. So that's all. Thank you so much for listening. Thank you so much.
Thank you so much, Ms. Salako. Your presentation is very, very interesting. Do we have any questions regarding the presentation? Any question? Okay, while we ruminate on what questions to ask, I want to quickly recognize the presence of Professor Q, one of our nurse leaders and diligent leaders who are always giving we the young ones support. Even though she's retired, but not tired. Anytime Alpha, Beta, Sigma is doing something, she's always available. So you are very much welcome, Professor Kilma. Will you just say hi to us? Style around now. She actually gave information that she has another engagement, but will come around soonest. And now she's available. So you are welcome to our conference, ma'am. And I hope since your presence, you've been enjoying our presentation.
Yes, I have. Thank you.
Okay. Thank you, ma'am. That's Mama Q for those who don't know her. Just try to scroll to see our mama. Thank you, ma.
Thank you.
Professor Tayoma, you are very much welcome. And then Dr. Atekoja is also online. Thank you for attending. Okay, so we go back to the presentation. Is there any question?
I think somebody is raising her hand.
All right, you have the floor, please.
Thank you very much. I want to appreciate and commend the presenter for a job well done. I love the topic, hospice and palliative care. I want to first contribute by saying that one of the benefits that this will give our patients is to be able to do justice to will and legal issues, especially when it comes to property, sharing of property, and lots more. Because some of that this is one of the things that causes issues, even when we have people that die in old age, especially when they have a big family. So it's one of the benefits that is occurred. Then I want us to just deliberate on this, that in the hospital care, in the clinical setting, when we have collaboration, collaborate together with other healthcare experts, doctors and others. And at times it becomes an issue when you know the diagnosis of a patient and you know that this is a palliative care. And this is not well explained to the patient. And sometimes when you begin to talk to the patient on their wellness, you want to improve their wellness and be able to take them through this palliative care, it becomes like you are wishing them back. And they think, what are you doing? And so I want our presenters to shed more light on how do we balance this when the doctor is not telling the patient that this illness is a palliative care, or they are telling them that it's true that we continue to encourage them, but most of the time they don't know the prognosis of their condition. How do we go about it?
All right. Thank you so much for that question. I really appreciate it. And I would say that this problem is something that is most often time experienced when it comes to a patient that needs palliative care. But what I would say is that in a situation where the doctor is not being vocal about the need for palliative care to the patient, I think the first step that should be taken, since we are recognizing that we all are a team, the first step may be to go see the doctor and discuss about the patient with the doctor. And after hearing the doctor's opinion, the doctor may have a change in opinion, or may understand your perspective and really see that, oh, there's a need for us to discuss palliative care with this patient. And doctor may also go on to meet the patient and have discussions. But in a situation where the doctor is not accessible, the doctor is not receptive to such opinions and such suggestions, that again is another unique problem that some nurses may experience when it comes to the healthcare team. So at this point, I really believe that the patient is at the core and center of any patient care, of healthcare services. The patient is at the core, patient is center. I think at that point, when the doctors are not being receptive to that suggestion, doctors are not seeing it. And if the nurse can also review the cases, other nurses and other healthcare professionals aside that doctor, and they all come to the conclusion that, okay, yes, the patient actually does need palliative care, I think the nurse can step in and speak to the patients or family members about that possibility. So I think that's all I have to say about that. And I'm looking forward to others' responses regarding this issue, because that is just from my own perspective. So I'm really eager to hear the perspectives of amazing nurses and leaders that we have here. Thank you so much.
Thank you very much. Then may I add that how do we go about the issue of palliative care with continuity of care? What do I mean by that? When you know that this care, the patient is on palliative care, or the patient's prognosis is poor, and you still have to go for big tests that will cost the patient or the relative more money. And they are coming to you. Should they go? Do they have to spend that much? Especially when you have big test diagnosis tests that going to cost them millions of naira, a lot of thousands, and they will be coming, especially when you let them know that this is a palliative care. How can we navigate that as not? How do we go about that? That will be able to, how do I put it? That will be able to bridge the gap. How do we do that? Thank you.
Hi, Ismail, and thank you so much again for the question. So in that case, I think is a very common practice in our healthcare system when they know this patient's prognosis, but they still refer the patient to go for diagnosis and yes, exactly. So I think at this point of view, I think the best or the first thing to do may not be the best, but the first thing to do again is to go back to the doctor and express ourselves, because we nursing, we need to always be expressive. Because when it comes to the healthcare team, it is not a one-man decision. It's supposed to be a group decision. Every member of the team should be aware, and discussions like this should be very common when it comes to patient and doctors and nurses discussing the patient condition and the best way to go forward. So I think it is also important the first step that should be taken is to see the doctor and discuss with the doctor and ask the doctor what are the needs or what are the indications for this diagnosis test you have asked the patient to do, and what will be the effects or what will be the what is the purposes of this test to understand better the doctor's perspectives. So after listening to that, I think then we can make a decision that will benefit the team and also benefit the patient, because patient is at the core of these healthcare practices. But again, I'm looking to hear other perspectives because I also like to be further enlightened about this particular situation. Thank you so much.
Thank you.
Okay, thank you. Are there other perspectives, just as the presenter has requested?
Yes, my own point of view is that we need to build the infrastructure of palliative and hospice care in Nigeria. Because if we use the current infrastructure that we have, the current model that we have in Nigeria, it's not going to deliver the best results. So when it comes to the question Mrs. Ilugbaro asked, the only problem there is we don't have a standardized model for palliative care. Otherwise, nurses should be actively involved. Doctors, even before a decision is made, people should be consulted. Even the patient's wishes should also be consulted. Now, we have been having this paternalistic approach where the physician make most of the decisions. That has actually been counteracted. That is no longer a working model. Now, it is now a collaborative model where patients are even seen as active participants in their own care. So if we are able to revamp these, structural realities, I think it's going to give us a better result. So the whole thing is going back to building a better palliative and hospice care infrastructure within the Nigerian context. Thank you.
Thank you, sir.
Wow. I'm sorry I've been muted. So thank you, Ms. Salako. So I was saying that we'll be moving on to the third part of our poster presentations. Meanwhile, we have just an hour to round up or to close in on this conference. And so we need to move as much as possible. So for this round of the presentations, I will be giving the presenters 10 minutes to present. You have just 10 minutes. So starting with Tanko Ota, who will be presenting on quality work life of nurses, Niger State, during COVID-19 pandemic. You have the floor, Tanko Ota. 10 minutes. Thank you.
Yes, che comprensione mettete, ma
You have the floor, please. Hello. Tanko Ota. I think we should move to the next presentation. Probably our network is not really good. Okay. Knowledge and perception of uterine fibroids among women in Ogun State by Olabisi Mary Olusheye and Boluwatife Adeosun.
Thank you so much.
Hello, can I present?
Please go on. Thank you.
Okay. Good afternoon to us all. Standing on the already existing protocol, the topic we are presenting this afternoon is knowledge and perception of uterine fibroids among women in Ogun State. And presents together with me is Boluwatife Adeosun. I am Olabisi Olusheye. Uterine fibroids are disorders commonly found among women of reproductive age, and it is of a public health significance. These are benign tumors that often grow in women uterus. The maternal mortality and other complications associated with human fibroids are common among Black women than the white women. According to Issa et al. 2019, the prevalence rates of uterine fibroids globally is around 4.5% to 68%, while in Nigeria, it is 45%. The cause of uterine fibroids is unknown. However, there are so many predisposing factors to this, and this includes low parity, smoking, alcohol, older age, among many others. Women with uterine fibroids usually do not present with signs and symptoms. However, some do. And this actually depends on the size of the fibroid in the uterus. The treatment of uterine fibroids includes the use of certain medical agents like Buserni, insertion of IUD, and also uterine artery embolization. However, the commonest method that is used in our community here is surgical removal of the fibroids. Issa et al. Identified that many women will not choose to undergo surgical procedures due to inadequate knowledge of this procedure and their perception of it. Many women consider it that it can lead to death, and also it can lead to infertility. And many women in our society will opt for alternative methods, which have contributed to the high level of maternal mortality in our society. And this was also observed among the study population. The method. The study employed a descriptive cross-sectional survey. A total number of 440 women were selected using multi-stage sampling technique. The setting is in a community in Naro, Ogun State. The instrument used was structured questionnaire, and which was validated, and the reliability was checked, which the value is 0.75. The data collected were cleaned and transformed using SPSS, descriptive and statistical inferential were used to analyze the data collected. The descriptive analysis was used to analyze the objectives of the study, and why the inferential was used to analyze the hypothesis of the study. The result shows that majority of the respondents, about 81.6%, had no knowledge of uterine fibroids, and 57% have negative perception of uterine fibroids. It is important that I highlight some of the way the mothers perceived uterine fibroids. Majority of the mothers agreed with statements such as surgical interventions is not the best approach in treating uterine fibroids. And also majority of the mothers considered surgical operation has been deadly. And also many of the mothers considered that removal of fibroids using surgical operation can lead to infertility. And also, the statistical inferential analysis done revealed that there exists relationship between some certain social demographic factors and the knowledge and perception of women towards uterine fibroid. The age and the level of education were the main social demographic factors identified. In conclusion, deaths due to poor management of uterine fibroids are prevalent among women of reproductive age in our society. Many women do not opt for medical interventions even when diagnosed due to their inadequate knowledge and negative perception of fibroids. The roles of community health nurses in the reduction of maternal mortality in our society can never be overemphasized. There is a need for more intensive public awareness and enlightenment programs on uterine fibroids and their impact on women's sex. Thank you.
Ross, please come.
Thank you for listening.
Thank you for the presentation, Mrs. Olusheye. Are there questions concerning the presentation? Okay, Professor Woziche. You can see your hand is raised.
My bad. I'll bring it down.
Okay. All right. So in the absence of no question, we'll move to the next presentation, which is on knowledge and acceptability of cervical screening among women of reproductive age in the University of Nigeria Secondary School, Enugu, by Ndubisi and Madrakula. You have the floor. I doubt if they are on this call. So we may just, in the next 2 minutes, go through their presentation. We move on. Okay, I hope we have gained something. So we move on to the last poster presentation for this virtual conference, which is to be presented by Rosita et al. On mothers' experience and compliance with immunization of under 5 children in Unko community, Yakor local government area of Cross River State. The floor is open now.
Good evening, everyone.
Good evening.
Can you hear me? Can you hear me?
Yes, we can. Go ahead.
Yes, we can.
Hello. Okay. My name is Rose Basio Rorita. My topic is mothers' experiences and compliance with immunization of under 5 children in community Yakor local government area of Cross River State in Nigeria. Introduction. The quest for ensuring a healthy living as well as promoting well-being for people at all ages by 2030 is a critical agenda for human development, as indicated specifically in goal number 3, nation success. Providing strategies aimed at preventing or eliminating completely the spread of communicable disease or epidemic have been a major concern of World Health Organization. Apart from personal hygiene, of washing of hands and other things, childhood immunization has proven to be one of the most successful strategy adopted is met. What is the purpose of this study? The purpose of this study is to explore mothers' experiences and compliance of immunization of their under 5 children in co-community. 4 specific objectives were raised. One of it is to assess the level of knowledge of the women. The second one is to determine the level of compliance. And the third one was to assess factors influencing mothers' compliance of their under 5 children to immunization. And then the fourth one was to explore mothers' experiences. And the method that was adopted was MIS method. MIS method was adopted in this study. And then the design was convergent parallel design. Convergent parallel design is a design adopted in this MIS method. Data collection was face-to-face administration of the questionnaire on the spot collected. And then the focus group discussion was used in getting qualitative data. The instrument was self-structured questionnaire, and the focus group guide was used in the qualitative study. Descriptive and inferential statistics were used to analyze the quantitative data, while the data collected, can you hear me? While the data collected qualitatively were formed in teams and hello? Can you hear me?
Yes, we
We can hear you. Go ahead.
Oh my God.
Go on.
Okay, thank you so much. I'm sorry. I said the MIS method was used, and then the design was convergent parallel design. Face-to-face collection of questionnaire was carried out, and then in the qualitative aspect, the focus group guide was used. And descriptive and inferential statistics were used to analyze the quantitative data, while thematic analysis was used for the qualitative data. 425 mothers were selected for the quantitative study using multi-stage sampling procedure, while 40 women were purposefully selected for the qualitative study. The results: knowledge and compliance. Most mothers, 75%, possess good knowledge in that community. And then more than half, showing more than half. And then the compliance level was moderate. The women there, compliance level was moderate. And then there were so many factors that were seen to be affecting them in carrying their children for immunization. We have the major socioeconomic factors, we have providers-related factors, and we have other demographic factors. Like the socioeconomic and provider factors influencing mothers' compliance include indecision, where a woman cannot take decision by herself because of her negative prior experience. And then the long waiting time also influenced them from taking their children to immunization. A woman who has waited the previous time so long a time in the immunization center may not want to go. And by so doing, it will affect the child from getting the immunization. And then in the qualitative aspect, where I said is to explore the mother's experiences. The mother had past negative experiences and had positive experiences. Of course, it's the negative experiences that will affect the timeliness of the immunization. I have here access difficulty. A woman who is living in a place that the topography cannot allow her to access the immunization may end up making the child not to get the immunization. The child may miss the immunization. Unavailability of drugs and unavailability of drugs and personnel. A woman who has taken the child for immunization center and BCG is not found there. The healthcare personnel kept on telling her, "Madam, come the next time, BCG will be available," will end up missing out the BCG or not taking it at the stipulated time. Also, one of their negative past experience was attitude of healthcare personnel. I quote, a woman said, "Madam, I cannot meet this nurse to give my child immunization because the last time when I come hospital, the woman shouted at me. She did not know what I passed through. She almost slapped me. So this woman will not never give my child immunization till I die." That statement has affected the child from getting that immunization. Untimely services.
Please begin to round up, ma'am. Begin to round up.
Untimely service delivery also will affect the child. There was a relationship between knowledge and compliance when the hypothesis was analyzed. Decision and conclusion. There is good knowledge of childhood immunization. Despite the knowledge, the level of compliance with routine immunization in the community was moderate. These findings were supported by some authors. Recommendation. A result-oriented and comprehensive educational intervention should be carried out among women in the community to augment the knowledge status of mothers on childhood immunization and further discourage negative religious and cultural beliefs regarding immunization of under 5 children in that community. Thank you for listening.
Thank you.
Thank you so much for that presentation. Any question for?
Please, my hand is up.
Okay.
Please go ahead.
My hand is up.
Please go ahead. Sorry,
It's been a very awesome time. I enjoy this thing and I thank you so much for organizing this program. Please, mine is not a question, it's a request. My poster has not been called and I was asked that when there is time, I will be called up to do the presentation. And I noticed that it's not yet 5. So please, with due respect, I'm requesting that you give me even 5 minutes to present on quality of nursing services, a systematic review. Akbanjeni Church is my name. Please.
Yeah, we were actually calling for questions for the previous presentation. So when we are done with that, then we can consider yours.
Thank you so much. I appreciate it.
Okay, so are there questions? Please drop your hand, ma'am. Mrs. Church. So are there questions for this the current presentation? Okay, I doubt there is. So at this time, we should have come to the end of our poster presentations, but we will give Akpan Jenny Church 3 minutes because she's supposed to be the second presenter for the first part
please. Good
of the
afternoon,
poster
everyone.
presentations. But then she was called at least 2-3 times. She was not available. And we have spent that time in presenting or in showcasing our poster. But now she wants to present. We will give her 3 minutes to give us a summary of what she has done. So you have the floor, ma'am.
Thank you very much. My presentation is on quality of nursing services in public hospitals, a systematic review by Akpan Jenny Church, Professor Gaji, and Professor Ikwe. Introduction. The increase in the level of nursing services for healthcare consumers, families, groups, communities, and population increases the likelihood for desired outcome. I hope I'm heard. Patient satisfaction is one of the key indicators of the quality of care. The aim of this review was to synthesize eligible evidence on the quality of nursing services in the public hospitals. And the method employed was done using a review using studies identified from PubMed, CINAHL, and EMBES. 27 studies, 12 qualitative, 1 mixed method, and 14 quantitative were included. The reporting items for the systematic review, PRISMA, and meta-analysis guidelines were used. Now the results. Out of 434 literature retrieved, 27 descriptive studies were retrieved. The chi-square statistic indicated a significant association between medical facilities and quality of nursing services in the public hospitals by P equal to this. There was no statistically significant difference between patient prior health status and their satisfaction with nursing care. Job performance at the P level of this. There was a significant difference at P less than 0.5 between the number of patients in a room and nurses' job performance. Patient had poor perception in some areas of nursing care. Nurses-patient relationship and nurse-patient communication were significantly related to the patient perception of quality care rendered to them respectively. In conclusion, there was a need to involve stakeholders, including patients and the public, in setting priorities for nursing care. My recommendation, I recommend that periodic research on patient views should form a basis for continuous quality improvement in nursing practice. Thank you so much for the opportunity.
Thank you, Mrs. Akpan, for keeping to time. I'm impressed.
Thank you. Thank you.
Thank you for that presentation. Do we have any question? Looks like our audience are now very tired because when we started, there were rows and tons of questions, but now the last 3 presentations, nobody is asking. Well, thank you for all the presentations. Thank you for making this conference a reality, and as such, a successful one. We have finally come to the end of
Hello, please. Hello? Hello, please. I'm raising up my hand.
It's okay. Please go ahead, ma'am.
Thank you very much. Please, my name is Mifaman Dubisi. I have a poster, but I wasn't called, and I've been here since 12 o'clock.
No, ma, we've called it a couple of times. You weren't aware.
Hello?
We called you a couple of times. You were not available when we called you.
I've been available. At a point, I was locked out and I even complained. I told me to log in with my meeting ID, which I did. So please, I'm sorry about that.
You have
Is
3
it
minutes for your
possible to...
presentation.
Thank you
3
very much.
minutes for your presentation.
Thank you
3
very much.
minutes.
Thank you. My paper is on, good afternoon, everyone, and thank you for that. My paper is on knowledge and acceptability of cancer screening among women of reproductive age in University of Nigeria Secondary School. The study was carried out in Enugu. By way of introduction, we just say that well, like we all know, is a leading. Approximately 90% of deaths occur in low and middle income countries, and Nigeria will have the highest death rate in the whole of Africa. And it's relatively rare. I mean, cervical cancer in high-income countries where there are organized screening programs. So that is why we wanted to look at the screening availability and uptake among women of reproductive age. These are the objectives of the study. We wanted to look at the level of knowledge, level of acceptability, and factors, especially personal and social factors that affect cervical cancer screening uptake. We used descriptive cross-sectional study, and then we used all the females, both academic and non-academic staff of University of Nigeria Secondary School, females only, and we had 120, and we used all. We used researcher-developed questionnaire for the study, and this questionnaire contained 39 items that are arranged in 5 sections and 4-point Likert scale. The results actually show that the majority of them had good knowledge about cervical cancer screening. But the irony is that even though they had this good knowledge, they had very low, low acceptability of the screening uptake. Then again, when we looked at the factors that affect acceptance of cervical screening uptake, we found out that it's majorly professional discomfort, professional problems, like the healthcare professionals and their discomfort that's associated with this cervical cancer screening. Then sociocultural factors were majorly socioeconomic, the economic availability, the costs of cervical cancer screening uptake. So these are our findings, and we concluded that that even though there is good knowledge of cervical cancer screening, the acceptability is quite low. And because acceptability is very low, there is need for increased awareness of this cervical cancer screening and to encourage, especially women of reproductive age, to accept cancer screening uptake, because once it's accepted, of course, definitely the rate of spread of cancer, the rate of increase in cancer spread will be reduced. Thank you very much, and thank you for the opportunity.
Thank you for the presentation. Do we have any question for? Is there any question? We are eager to leave. In the midst of that, I want to be very sure that we have gained new knowledge, which will serve as evidence in our subsequent nursing practice. So I want to still say that, is it on behalf of the committee and then the Alpha, Beta, Gamma chapter, even though we are all members, that you are appreciated for making this virtual conference a reality. For everyone that has submitted their research work and have presented, thank you for rising up to that challenge. I got an instruction here that Dr. Nwozichi will be awarding 20,000 naira to the best abstract presentation. Okay, so votes are going on. The committee is expected to send in their votes on the best abstract. So please, if you have presented, do me the favor of waiting till the end. You never can tell. You may be the best, your abstract or your presentation may come up as the best, and you go home with some cash. That is enough. That can go a long way in this our present Nigerian economy. So please be on the watch, stay on guard, and probably start praying. Luck will shine on you. Be that as it may, we will move on to our goodwill messages. I noticed the presence of our African regional coordinator in the person of Sylvia. I saw her pop in, and I want to, yes, Sylvia Oga Ofosu Dwamena. I noticed her presence as one of our dignitaries. Thank you so much. We will go on to the goodwill messages now, and I will be inviting or calling on our dignitaries, invited guests, to give us some goodwill messages, and then appreciations, comments, observations in respect of our conference. So in no particular order, I will just call, and I will start with Mama Kyo. Please give us some messages that will gladden our hearts. Mama Kyo, you have the floor, ma.
Thank you. I'm so glad I was able to join, even though I had some difficulties in coming in earlier, but I'm thankful I was able to join the conference. This has been a stimulating topics that were presented, and I'm glad for those who have presented, and I wish them good luck and more grace to their elbows. And I pray that we will continue to put in the best we can as nurses to reflect the skills that we learned today, so that we will continue to do the best for our patients and our clients. So I wish you all the best, and thank you for your presentations. And I wish you all journey mercies as you go back to your destinations. In Jesus' name, amen.
Amen.
Thank you, Mama. Okay, I'll call on Sylvia Dwamena, our regional coordinator. You have the floor, please.
Okay, thank you very much. I want to congratulate the Alpha Beta Gamma chapter for this conference. It's been an insightful one. And then I want to remind all of us that our organizational call for action for 2023-2025 is to represent. And in representing, we reflect, we respect, and we respond. Also, I want to use this opportunity to inform us that there will be an upcoming conference, a regional conference, hopefully in South Africa, early 2025, God willing. Thank you very much, Alpha Beta Gamma chapter, and congratulations. Thank you.
Thank you, Sylvia. We are glad to hear from you. Okay, I'm seeing Mr. Yakatun, the chairman for the West African College for Nurses and Midwives. Thank you for attending our conference. Can you say something to us?
Yeah, good evening, everyone. Thank you so much for the conference. And on behalf of the President and Council of West African Postgraduate College of Nurses and Midwives, I bring you greetings. And the conference or workshop came at the right time, and it is timely. And I believe when next another workshop is organized, I'll ensure many of our fellows to join the program. It is very educating, and especially as it regards research. It will benefit the college, and I want to see a situation where the college can partner with the Sigma International so that we can train most of our fellows on aspect of research issue, because I know most of our fellow students are having problems with research. And if we can partner with some of you people, you use your expert knowledge to see how we can explore the situation. I'm very grateful for attending this program from beginning to the end. And I thank all the for much for thank you.
Thank you so much, sir. Village people did not want us to hear what Mr. Yakatuna said. But one critical message I got is the fact that we need to collaborate Alpha Beta Gamma chapter of Babcock University is lobbied by the West African Postgraduate College of Nurses and Midwives.
Hello. Hello. Hello.
Hello.
Yes, how are you?
Very well, sir. Okay, please pardon that intrusion. I actually don't know the person, but seems to be on this call as well. Okay, so moving on. The last dignitary I can see on this call is Professor Mrs. Grace Tayo, the director for RIC, Babcock University. Coincidentally, she will be rounding up our goodwill messages, just as the Yoruba people will say, Egunla lo ma kẹ́yìn ìgbàlẹ̀. Now, in English, it means that the last, what is Egun in English? Is
masquerade.
What is it? The last masquerade is the biggest masquerade is the one that will come out last. And so we are having Professor Grace Tayo to cap up our goodwill messages. You have the floor, ma.
Thank you very much, Dr. Baba Daly, for the welcome and for the introduction. On behalf of the research office. Hello? Hello, can you hear me?
Yes, we are with you, ma.
Okay. I had someone saying hello. Okay. Yes. On behalf of the research office, Babcock University, I want to congratulate the organizers and all the participants for a wonderful conference. I sent a message earlier that I will not be able to join you from the beginning, but I want to attest to the fact that since I joined about 1.5 hours ago, I have listened to the presentations, and I can say with certainty that these are excellent presentations. Definitely, we know that today that we talk about evidence-based practice, research is very important in our work. And I believe all that we have gained today will help us to be better service providers wherever we are, in the academics or at the bedside. I pray that the Lord will continue to strengthen us, and that's the Alpha, Beta, Gamma chapter of this great association. We continue to move from strength to strength. Congratulations. by God's grace, we'll be together again next time. God bless you.
Thank you, ma. God bless you too, ma. Okay, I can see Nurse Atekoja. Nurse Atex. Dr. Atekoja. HOD, Department of Nursing, Olabisi Onabanjo University.
Hello, good yes, good afternoon, everyone. Good afternoon, Dr. Babadili. Thank you for the for calling me up for the goodwill message. I apologize for joining a bit late. I was busy with some administrative duties, but the few moments I've joined, it has been a beautiful presentations, beautiful abstract presentations, and believe that nursing is going to places, and it's a beautiful conference. We would like to have more of this going forward. Thank you. God bless nursing. God bless Nigeria. Bye-bye.
Thank you, Dr. Atekoja. Okay, I want to ask the committee members if they are done with the voting so that the presenter with the best abstract can be announced. Okay, I've been reliably informed that the Provost College of Nursing Oyo State is also on the call. Please pardon me, ma. You have the floor now, ma'am.
Experience of midwife in the management of normal level. Who has that? First one is 8 points. Second one
Thank you
is
very much. My wonderful
7.3.
I must confess that I've been saturated today. Such a great privilege to be part of this. I pray that God will help us move this profession forward. To the glory of God. I want to congratulate the organizers. You have done a great job. And you have really, really sensitized us to do more. So from Oyo State to wake up. Thank you very much.
Thank you, ma. Okay, so we have actually come to the end of the conference. I think the next activity should be announcing before the vote of thanks and the closing prayer. I think the next activity should be the announcements of the abstract. Okay, there is a presenter that is now available and is yearning to be called. Dr. Tanko. You have 3 minutes, please. Dr. Tanko. Dr. Tanko. Dr. Tanko is to present
Hello.
on.
Good afternoon, good evening.
Thank
Hello.
you. You have three
Hello.
minutes,
Hello.
please. Hello.
Hello, are you hearing me?
Yes, we can.
Are you hearing me? Hello? Are you hearing me? Are you hearing me?
We can hear you, sir.
Yes,
Okay.
yes, we can. Go on, please. Go on.
Okay, it's okay. Good afternoon, good evening, sir. The title of my topic is Quality Work-Life Balance of Nurses in Niger State during COVID-19 pandemic. I will start by giving brief, though I've been giving only 3 minutes, brief discussion on the variable that will be affected The concept of quality of life has been evolving in recent years. One example is the concept of health-related quality of life, which is defined as comprehensive concept that includes all factors that affect person's life. Work-life balance is very important in life of professionals, especially nurses, because nurses work during every pandemic and in all harsh conditions. Nurses are the most diverse workforce and the life wire in the health industry, as well as the largest group and frontline workers in healthcare system globally. Their absence in the health sector can lead to poor quality of hospital service to the patients. Hospital, on the other hand, basically the health industries, shouldered with the responsibility of providing healthcare services. Nurses, therefore, are the most significant group among healthcare professionals, and the stability of their team significantly affects the quality of care. On the other hand, healthcare is one of the most complex activities in human activities that human beings engage. So quality of nurses' work life is the ability to meet up the organizational goal and obligation through the knowledge, skill, and experience of nurses without compromising their own social life. Unfortunately, in most cases, their own welfare is totally ignored. Therefore, quality of life is a measure of an employee's quality of life within the context of work that seek to assist factors of work environment as well as factors of life outside the work. Quality work life also consider the relationship between work and life outside the work of the employee. So I will be discussing it, or I will further briefly talk about the variables that are involved. And the three variables I chose were depersonalization, emotional exhaustion, as well as personal accomplishment. Under the personalization, it is a feeling that an individual feels either within or outside, which is not real, or one that is real inside within the body. So one passing through the feeling of this sort is normal, but certain professionals such as nurses might find that it is, when it is persistent, it can become significantly, or it can significantly affect or interfere with one's daily activities. So it is certainly possible, however, for nurses to remain unaware of the personalization that take effort to deal with them. So since this study was conducted during the COVID-19 pandemic, it should be noted that the disease has seen a great number of protocols, policies, and procedures implemented in hospitals which were constantly reversed. Hence, the nurses then found it challenging to maintain very good working relationship or working work balance. Emotional exhaustion, on the other hand, is the feeling where an individual is emotionally drained and worn out due to accumulated stress resulting from overwork.
2 minutes more. 2 minutes more.
Okay. So emotional exhaustion is in healthcare, reduces healthcare workers. Personal accomplishment is a goal that one has reached or about to reach, or an objective an individual has set up to meet up. So with all these variables, I will now go to the conclusion. The objectives, the specific objective was to explore the quality work-life balance of nurses during the COVID-19. Methodology used was descriptive cross-sectional design. Result show that overall, or majority finding reveal that participants' quality work-life balance was moderate. That is to say, it was not below and it was not, they didn't enjoy the very well and it was not below. What could be explained for that is because there were no much cases of COVID-19 in Niger during that period. Conclusion, overall finding revealed that participant quality work-life balance was under depersonalization, emotional exertion, and personal achievement was moderate. Recommendation, even though their quality work life was moderate, the researcher suggested that training of nurses, especially the new ones or the younger ones, to combat any emergency, provision of materials like PPE, that is private protective gadget, as well as further research should be conducted in order to facilitate or to enhance quality work life of nurses, not only in Niger State, but other parts of the country? Thank you.
Thank you,
Hello.
Dr. Tanko, for your presentation. Okay, so do we have a vote now? The committee.
I'm here for the vote of thanks.
No, there is still there is an activity that should go on now. The committee members are expected to vote for the best abstract, who will be awarded by Dr. Uwoziki for with the sum of 20,000 naira, and he will communicate with the presenter via email for his or her account details. But then I think the submission I have here for the best abstract presenter is Dr. Ekaite Asuko. Dr. Ekaite Asuko presented on Dr. Ekaite did a presentation on, I'm trying to look for her work. Yes, she did a presentation on the lived experiences and coping strategies of women experiencing fertility challenges in University of Calabar Teaching Hospital, Nigeria. Dr. Ekaite Francis Asuko. Thank you so much. Congratulations to you, ma'am, for your presentation. And then your abstract. This does not mean that every other abstract presented are not good, but you know, there are times when we just do activities like this to encourage others, and then to, to encourage and to motivate for more of it, in as much as considering the fact that we need to be engaged in a lot of insights that will produce evidence-based nursing practice. So congratulations, Dr. Asuko. The vote of thanks now will be given by Professor Samson Akpan. You have the floor, ma'am. Professor Samson Akpan, for the vote of thanks. Okay, if she's not available, Dr. Lawal. Oh, okay, Professor Edet. Professor Olaide Edet for the vote of thanks. Professor Olaide Edet for the vote of thanks. You have the floor now, ma'am.
Oh my God. Okay. Through the chapter chair, it's my pleasure to take on this on behalf of Professor Patience Samson Akpan. We would like to extend our profound gratitude to the keynote, the person who gave us the keynote address. I think is Dr. Ayambi. We also thank all the speakers, those who gave the lectures on evidence-based nursing. And then we also thank all our presenters, those who presented abstract. That was very, very interesting. We are very grateful. And to all our colleagues that found time to send us goodwill messages from different parts of the country. West African College of Nursing, the executive secretary, the Oyo State College of Nursing provost, and all other ones that I may not mention. We are very grateful. And for the members of the planning committee, right from the chairperson to all the members, we want to express our heartfelt gratitude. You have done a good work. We have been able to attract almost 50 participants, and the topics that have been handled are also very, very apt. To Babcock that has hosted us, we want to thank the Dean of the Faculty of Nursing, Professor Showumi, for providing the enabling environment. Then also for Nosology Academy that handled the ICT. We are very, very grateful. And for all those who even participated, that is without presenting any abstract, they just joined us and to extend their knowledge and to ask questions and to make some very useful contributions. We express our heartfelt gratitude. Please, if I've left anybody out, it's not deliberate. All of us that have contributed in one way or the other, even to the registered participants who just came, we are very, very grateful. Thank you for coming, and we hope to see all of you next time. I'm sure that the committee will make available the recordings so that we can go back and check one or two things to improve the quality of our service. Thank you.
Thank you so much, ma. God bless you, ma. Yes, Mr. Ademola requested to say a few words. So please go ahead, sir.
Thank you very much. Sorry, I think the network threw me out. I just want to show appreciation to the Meditated Society of Chapter for this laudable event. I really appreciate it, and we have learned. And I want to strongly suggest that such events should come in a short time. So really appreciate you. Thank you for this laudable effort.
Thank you, sir. The closing remarks by Dr. Lawal, the president for the chapter. Closing remarks.
Thank you so much, Dr. Okpekpopetele. In fact, I'm so overwhelmed. I don't even know what to say. I just want to say thank God and thank everybody who have been here. And I think a lot of people had problem with our country's problem, ICT. I think I was even thrown out once or twice during this period, and I don't even know, and I'm not even around. And I was saying that I thought I was going to be there throughout, and even it showed me here that it was low, and then the next thing I didn't see myself there. So I want to thank everybody. I'm so glad and I'm so grateful. Alpha, Beta, Gamma, we need many of you that are here. And I hope, like I said, that you are going to join us. I want to especially thank Professor Tayo because she had been a lecturer and she made sure that she was here. There are many people that were called and only a few turned up. And I said, I want to say thank you for all those that turned up. I want to say thank you to our South African coordinator. In fact, I was so surprised because I was saying, will she come or will she not come? She has asked us that all of us, we should be there for the induction ceremony. She will be here for the induction ceremony. So please, let us try and get it ready. I want to say another big thank you. And then at the end of the day, I want to tell us that we started promptly at 12. And when we started calling people, they were not around. Please, African time does not belong to us. Let us be here at the time that we are supposed to be here. We are closing exactly the time that we say we'll be off the line. And that is also very good. We pray that all of us we will leave for the next one. God bless you. Thank you very much, everybody, for coming.
Thank you, Dr. Lawal, for that encouraging words. God bless you, ma. We will close officially now, after all being said and done, with a prayer that will be said by Mrs. B. Okuboyejo. You have the floor, ma. Mrs. B. Okuboyejo. I doubt if she's on this call, or probably network. So please let us close with a prayer from Dr. Wozichi. Please lead us in prayer.
Okay, let's pray. Our Father and our God in heaven, we thank you for giving us this special opportunity. We thank you for your grace. We thank you for making everything work out perfectly well. Even though there were some technical hitches, but you and your grace will say, may your name be praised forevermore. And we also thank you for all the participants, the strength you gave everybody, for all the committee members, everybody. We pray that at the end of today, all of us will have renewed faith in our profession, and with your help, we'll continue to advance our profession to a greater height. Thank you for everything, because we have prayed with thanksgiving in Jesus' name. Amen.
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 Thank you, everybody.
Thank you for
Thank
this
you, Lord. Thank you, Lord.
organizing
God
this
be
function.
all the glory. Bye.
Hallelujah. Bye.
Thank you. Bye.
Bye-bye.
Well done. We appreciate everyone.
Thank you, ma. Thank you, sir.
Thank you very much. Thanks for the opportunity. Bye.
Did you mute me? I thought I was talking. I didn't know that I had been muted. Hey, thank God.
Okay, bye-bye. Dr.
It
Lawa.
is